Oh. Welcome back, committee. Committee will come to order. We gained some faces over lunch. Welcome, everyone. You know who you are because they're all looking straight at me.
I think it's a class.
It's a class. We'll have you come up and tell us who you are in a few minutes. How's that? Okay, the committee will come back to order. I believe we left with the certainty that we were going to ask someone, and we have at least 4 chairs up here for PBM representatives. So come on down. Welcome to Labor and Health. The first thing I want to do before you start testifying is right behind you, there's a group of suspicious looking students. And I'm curious who they're from. If one of them can stand up and tell us who you are and where you're from. Don't fight over who's going to stand up.
Hey, I'm Lauren. We're at 3 on the left. We're P4 is at Orange Care School Pharmacy. So we're on rotation here with IHS. And then 12 minutes. Yeah.
Excellent. Welcome to a very interesting discussion, which will affect the future of all of you. Very good. Let's go ahead and introduce yourself and proceed with the discussion. Turn on your mic. And introduce yourself before you get started.
Well, good afternoon. My name is Lugina Mendez Harper. I'm a pharmacist and I work with Prime Therapeutics. Prime Therapeutics is a pharmacy benefit manager, which I'll start using PBM now because it's less of a mouthful. We're owned by 18 Blue Cross Blue Shield health plans across the United States. So one of them being Wyoming, but we also work in other states like Texas. So I actually have worked in Texas on some of the legislation we talked about this morning. So before I get started, I want to just make sure, do you have a handout? Okay. I've given it to everyone last night, but so I was asked to come in and was given the topic of prescription drug costs and role of pharmacy benefit managers. And I was like, okay, can we get a little more specific? What do we want to learn about? And so what I've tried to do today is just go over a couple of general concepts. And I think it's good that the committee heard from other folks because you see it's a very complex system. And it's a lot to try and wrap your head around. So I wanted to just try and present an overview of it. And then just hopefully this is going to be, the first in a series of discussions where you'll have someone that you can talk to that's from a PBM that can serve as a resource to educate and inform, what activities you want to undertake in Wyoming. So I will start. What I did, this first slide here is just an overview of how, if you can go to the next slide. Of how, what I'm going to talk through. So the first 2 bullets are the general title of the presentation or that was on the agenda. And then when I read through the very helpful and informative LSO issue brief, it looked like it was broken into segments of like, what is Wyoming doing? What is Arkansas? What is this thing that happened in Arkansas? And then I wanted to finish up again, since I am a PBM representative, with key takeaways about what we are and what we do. So that's what we're going to talk about here. So kudos to both the speakers before me, Denise and Donna. It's hard to understand the nuances of prescription drug delivery, and they did a really nice job explaining a lot of this to you. So very good job there. So what this first slide here is prescription medicines. So what is it that we're trying to do with prescriptions medicines? I mean, the most important thing is it has to be accessible. It has to be affordable. If you can't afford it, you can't get it. Doesn't do anyone any good. So what consumers are looking for is access to safe and effective medicines. And someone earlier talked about the FDA, and that's their role, is to make sure that drugs are safe and effective. You want reliable access to affordable medicines. So can I afford it? And then can I get it wherever I am? And that's where we have our pharmacy networks. And then when we do is to try and bring down the cost of prescription drugs. Wanting to avoid drug-drug interactions. So a drug-drug interaction is, say you're on Coumadin, a blood thinner, and you take another drug that could make you bleed even more, well, you want to know that. That's what you were talking about earlier, where your pharmacist reaches out to you and says, did you want to dose that this high? Did you mean to do this? So one of the things is that the pharmacist, as you saw, the education that we have is really extensive. But we also have systems that help us that message to us and say, hey, oh, sorry, I thought somebody. We also have systems that tell us, oh, did you know that this patient got X drug and now they're getting Y drug? And that is a very helpful system because it tells us, to be aware of these things, and then we can engage with the prescriber and, say, were you aware of this? But one of the things that I wanted to just touch on briefly is with a PBM, we are getting claims from all pharmacies. So I'm getting claims from Kroger, from CVS, from Walmart, from, Joe's Independent Pharmacy. And so we serve as a hub of seeing what a patient is getting. So for example, let's say that you got that blood thinner at Walgreens, but now you're filling that other medicine that interacts with Coumadin at Joe's Pharmacy. Well, those systems may not know that, but they do know that because we will message, because we see the entire picture of everything, any pharmacy that you're going to that's submitting a claim to us, we're seeing that. So we're able to message and say, oh, this person just got that. So that was one of the things that we used quite effectively when the opioid crisis first started, to try and message and say, oh, did you know that they just got this 2 days ago from Dr. X? And so that's just one of the things I wanted to share with you. It is a hub system where we're able to message on that. And then the last one is, you need to know how to use your prescription drug benefits. So a lot of times we have to explain to folks, which pharmacies you can go to in Wyoming. Since you're such a rural state, most of our networks here for Blue Cross Blue Shield are open. So you can go to almost any pharmacy. But in other states where it's not as rural, we do have the ability to have some cost savings by having people go to specific pharmacies that have given good prices to the insurers. So, sorry, I'm cotton mouth. I'm getting over a cold. The other thing on the bottom here is just a general overview. There's 3 different major classes of prescription drugs. And I categorize them by how often they're used. So generic medicines are used the majority of the time, 85% of the time. But because they're generics, meaning that they're made by multiple companies, their costs are a lot lower. And so even though they're used 85% of the time, they only account for 15% of overall drug costs. Brand name medicines have a lower use, but they have higher costs because they're more expensive. So the way to think of this is, and I brought some examples because I was going to use it also to explain MAC. So think of brand name Tylenol, for example. This 100-count bottle that I purchased last night was $10. But then I purchased a generic and it was $1.97. So that's why you have that shift in, you're using the Tylenol brand less, but it's costing, it has a higher cost per time that you use it. So that's why those have that kind of divergence there. And then the third major category are specialty medicines. So these are the drugs that you guys have talked a little bit about it today. So you've heard some terms like biotechnology, and generally these are medicines that are very expensive. They're used for really complex diseases. One of the medicines that you can use it for multiple sclerosis, you can use it for hemophilia, different kinds of cancers. So those are generally those types of medicines. They're not used as much overall when you're looking at the whole picture of prescription drugs, but they're so darn expensive. So that's why you have them making up a big portion of the cost. So when an insurer or a payer is looking at, I need to provide my state employees or whoever it is, my employees, the state employees, I need to provide a prescription drug benefit. We're having to look at this whole picture. How do I manage the generics? So I want to drive people to generics because they cost less. I get more bang for my buck when I use a generic because I'm able to be a better steward of that healthcare dollar. I'm able to stretch it and make it go further. But in some instances, I don't have that option because sometimes when you have a brand name drug, that's the only option there is. And that's because of our federal patent laws. When a drug first comes out, they're the only option that you have. Once that patent expires, then that's where the generics come in and when we can start moving patients to those drugs to help, again, stretch our healthcare dollars as much as we can. So that's kind of the big picture of how somebody who is paying for prescription drugs has to look at the totality of the prescription drug market. So if we can go to the next slide. Let's take another drink, so sorry. So the drug supply chain, I have 2 slides on this and I did this purposefully and it's also in the LSO brief. But what I wanted to do is just explain one of the things that's really hard to get your head around from the drug supply chain perspective is there's 2 ways that we have to look at it. There's the flow of the actual drug, the actual tablet or pill or capsule, and then there's the payment. And so those are 2 separate things. They're interconnected and we'll show you the relationship. But I just wanted to start with the basics of how does a drug actual physical product move through the system? So you have drug makers or manufacturers that actually make the drug, and they are the entity that sets the price for the drug. They are the ones that say, I'm going to charge X amount of dollars for my product. We do not set the prices. We negotiate reimbursement for those medicines on the back end, but what a manufacturer charges for their drug is set by them and only them, and whether it's a brand name manufacturer or a generic manufacturer. So I want to make sure that I put that out there so we can talk through some of the questions that you guys had touched upon that nuance. So I wanted to make sure that that was part of our discussion. So drug, in the past, pharmacies could buy drugs as my colleague stated, they could buy drugs directly from the drug manufacturers, but the drug manufacturers were like, this is too hard to manage all of this. So now you have wholesalers. And pharmacies still can buy some drugs from drug manufacturers. But for the most part, the drug manufacturers will sell to a wholesaler, and then the wholesalers will then, they're these just big, huge warehouses across the United States that are just fantastic at getting drugs quickly to all of the pharmacies that need it, usually next day. Although maybe not in some of I know in some of our rural towns that I had in New Mexico, it wasn't next day, but that's they're more of a, let's get this out here. One of the things I also wanted to point out with the wholesalers is they are also, a lot of wholesalers will also have a PSAO, and that's another abbreviation, welcome to our world, Pharmacy Services Administrative Organization. And what those are they are companies that independent pharmacies can use to, they contract with PSAOs to negotiate with us their contracts. And they do a lot of other things as well. They help them with, they have a lot of services that the pharmacies can choose to use. So again, another nuance there. So I'd like to can we go to the next slide? And so you'll see on the left, my left, right? My left is still how the drug moves through how it moves through, the actual drug product. And then on the right, I've added how they're paid for. So with PBMs, what we're doing is the drug manufacturer, I'm just going to go down the middle here. With drug manufacturers, they set the list price of what their medicine is going to sell for. We go to them and negotiate the cost. So we go to them and we say, and it's so hard to do this without first talking about PBMs, and we'll get into a little bit more, but one of the things about PBMs that we do is that while we take the aggregation of all of the patients that we service, and we're able to negotiate with drug manufacturers based on all of the lives that we cover or that we provide services for. So for example, let me explain. There's say 80,000 Wyoming residents that belong to Blue Cross Blue Shield of Wyoming. let's say. And you could go to Pfizer and say, hey, what kind of price will you give me? I have 80,000 patients that could potentially use your drug. But because we represent a PBM, I represent 18 Blue Cross Blue Shield plans across the United States. I'm able to go to Pfizer and say, I have 20 million lives across the United States. What kind of rebate or discount can you give me for your drug that I can pass on, that is because I have all these lives that I'm providing services for. So we'll get into it a little bit more. It's hard to get into the drug supply chain without first talking PBMs, but I wanted to start with the overall picture first. And I already talked a little bit about PSAOs, how they negotiate drug price reimbursements on behalf of the independent pharmacies that choose to contract with them. We will contract with independent pharmacies directly if they so choose. And then healthcare insurance providers. So I actually call them payers, because when you think of a health insurance provider, you think of Blue Cross Blue Shield of Wyoming, or you think of Cigna or Aetna or any of those big insurance companies. But we also work for state programs. So PBMs will work for the state of Wyoming or the town of Riverton, if that's how they choose to do that. We work for large employers, so like Boeing and Amazon and things of that, where they have a footprint across the United States. And then we also work for trusts and unions that have, again, they cross multiple state lines, so we will work with them as well. So this is the point here on this slide, is just really to drive home the fact that it's very complex, because you have the drug flowing and then you have how it's being paid for. And they're interconnected, but there's differences there that have to be factored into the whole picture. So we can go to the next slide. So now we'll transition to what is a PBM. So PBMs, payers, again, which I described a little bit ago, they choose to contract with a PBM. They don't have to use a PBM. They choose to use a PBM to administer their prescription drug benefits. Typically, I like the image of the prescription, your healthcare card, because a lot of people are like, who are you? I've never even heard of you. What do you do? And so that red circle there is just really intended to show you we're here and we're part of the healthcare benefit, and we are helping administer that particular portion of your overall healthcare insurance plan. What do? We perform a variety of services to ensure high quality, cost efficient delivery of prescription drugs to consumers. So, I'll get into more detail. Let me just keep going. And then PBMs work to obtain lower costs by aggregating the buying clout of millions of enrollees. So that's what I talked about earlier, is where we're able to go in and say, we have a much more large footprint, so we can get a better deal from the manufacturers. The next slide is who hires PBMs. So this is, I've already spoken to a little bit already. We have private sector employees, public sector employees like the state, commercial health plans, as well as the unions and Taft-Hartley plans. So those are the ERISA plans. You can go to the next slide. This is a slide that just goes over the different suite of services that PBMs can provide. Again, the payers who we contract with determine if and what of those services they want us to perform for them. Some of the payers can do that themselves, and they do. Others will ask us to do that service for them because we have, the pharmacy and drug expertise in-house. So I'm not going to go into each of these because I can answer questions and things of that nature, but these services have evolved. All of these things, these suites of products that we offer, have come to be as the prescription drugs got more and more expensive. And as payers, as I said, when you're looking at how do I provide this benefit to my patient or to my enrollees, looking at that big picture of, the generics and the brands and the specialty drugs, as drugs got more and more expensive, and there was a lot more specialty care that needed to be coordinated for those drugs, a lot of these services came to be. So it's something that has matured over several years. So we can go to the next slide. So I wanted to answer a question: why do payers hire PBMs? Again, our goal is to help payers have access to affordable medicines. They don't have to use us. What typically happens is a payer will say, I'm going to provide a healthcare benefit that includes prescription drugs for my employees. Or they'll go to a health plan. The health plan will say, we have all of these enrollees in our health plan. We're going to use a PBM, and that it's a competitive RFP process. So they come to us and say, I have this many million lives that I'm covering, or 1,000 lives. And I have this amount of money that I can allocate to provide a prescription drug benefit. And then the PBMs will go in and compete and say, I can do this service for you this way, or this way, or this way. And then this PBM will do the same thing. That payer looks at all of those proposals and then selects which PBM they're going to use and which services they want the PBM to provide. But again, why do payers hire us? They can do it themselves. But that slide where everything's moving and there's pieces and parts and everybody's interconnected, it's very nuanced. And so a lot of payers rely on the expertise that PBMs have. We're pharmacists that can dig in and say, this drug came out for this disease state, and there's this drug that's for this same disease state. How do they compare? Are they, which one should we cover, and things of that nature. So there's some expertise that PBMs have because we are the pharmacist, prescription drug experts, and we have a lot of resources that we can dedicate to digging into the prescription drugs that are available for different diseases. So some of the programs that we have is in improving medication use and patient outcomes. So some of those programs are things like, if you have diabetes, generally you want to be on a lipid medication because we know that that's a comorbidity and we want you to be treated for those two diseases. So we'll message to physicians, we'll message to pharmacies and ask, can you start this dialogue? We also will message directly to patients. Sometimes patients will get letters in the mail that'll say, hey, we noticed that you didn't get your blood pressure medicine filled. It's really important that you take that. We just want to check in and see how what's going on there. So again, we're trying to help payers control drug spend by delivering those drug savings to payers and their members. And we're actively working to reduce the high costs of prescription drugs. And we'll get a little bit into that. Next slide. All right, this is a slide that I think brings it all home, because it's kind of, it's hard to wrap your head around until you have a real life example where you can touch it and feel it. This is an example I use for hepatitis C. So hepatitis C is a chronic condition. And a couple of years ago, a drug came out on the market that actually cured hepatitis C. Let me say that again. It cured hepatitis. Like all of the drugs that we have treat. This cured hepatitis. Like it was mind blowing. It was like you were just like, I can make this disease go away for these patients. I can change their lives forever. It was a phenomenal advancement in the practice of medicine. And as we're looking at the drug, we're like, well, this has to be on your formulary. You have to cover this drug. It's a cure. But then you look at how much it is. When the first one came out, Sovaldi, it was $1,000 a pill. And you have to be on this therapy for 12 weeks. So overall, we were spending $83,000 to cure that patient. But again, what you're trying to balance is, I'm going to cure you, but it's $83,000. How do I, as a payer, how do I do that? How do I balance that? How do I pay for that? Because that's $83,000 is a much different price tag than what you're used to with blood pressure medicines or anti-inflammatory drugs or things of that nature. So it was a huge issue because payers were grappling with, I have to provide the coverage and there's nothing I can do because it's $1,000 a pill. It's the only drug on the market. That's what they've set their price at. So that's what we have to pay. So in a year or 2 years down the road, other hepatitis C drugs came to the market. And once there was competition on the market, that's when the PBMs were able to come in and leverage our buying power and leverage our expertise to bring the cost down. So what did we do? When there was competition on the market, first thing we look at is there's 3 drugs on the market that are for hepatitis C. Do they all cure it? Are they equally safe? Are they equally effective? Okay, that's the first thing we're going to look at. Clinically, do these drugs do the same thing? Can you use them for hepatitis C and will you get the same outcome from them? Yes. Okay. Now let's look at cost. They each had their own price tags. But what we as a PBM were able to do was go to each of those manufacturers and say, okay, this is a fantastic drug. It cures hepatitis. You have your price tag and that's fine. But I'm coming to you with 20 million lives. And looking at those million lives, we think that 5% of our patient population has hepatitis C. So that means we have this amount of patients that we need to treat. We're going to bring you those patients. What kind of deal will you give us? What kind of a discount or a rebate will you give us on that medicine? And in turn, we will add that drug in a preferred tier on our formulary so that's the drug that's used instead of the other drug that isn't giving as good of a rebate. So does that kind of okay. It's such a complex thing. And but this is just a great, first of all, I just love it because it's hepatitis C. And when you can say we cure you as a pharmacist, as any kind of healthcare provider, that's what you want to hear. But again, it just helps to illustrate what PBMs did. And so when we were able to do that and come in and reduce that cost from $1,000 a pill to $589 a pill, then you had payers like different state programs that were funding Medicaid or state programs that were funding healthcare and prescription drugs for their state employees, or health plans like Blue Cross Blue Shield of Wyoming, who are covering a lot of people who've purchased plans through Blue Cross Blue Shield of Wyoming. We were able to deliver that savings and bring down those costs. And how do we do that? So we'll talk a little bit more about how that happens. So the next slide here, transitioning into, again, looking at the LSO write-up. I'm not going to spend a lot of time here because a lot of speakers have talked about House Bill 35 from 2016 and House Bill 63 from 2019. But one of the things that I wanted to point out, in House Bill 35, we've been talking a lot about MAC. And one of the things that was said earlier was MAC is essentially the list of drugs that are covered. And I want to just back up a little bit. MAC is specific to the generic drug market. A formulary is the list of drugs that are covered, but it's not just generics. It's also the brand name drugs and those specialty drugs. Again, the formulary is a list of drugs that we cover. So it's that all 3 of those buckets. So MAC, and I'm going to use this example because Chairwoman Wilson had a great question. I've tried to explain MAC several times, and it's such a hard concept to understand that this is the only way I've been able to figure out to do it easily. So here's your brand name Tylenol, and these are 3 different versions. These are all Tylenol. This is all acetaminophen, all the same strength, but they're made by different companies and they have different prices. So what MAC does, MAC has nothing to do with brand name Tylenol. What MAC is saying is, this one was $10. This one is $15. This one is $2. They're all acetaminophen. What a MAC list says is like, there's all these different manufacturers that make the same drug. We want you to buy we don't want you to buy the $15 one. We're trying to incentivize you to buy smart, buy these ones that are less cost. And that's what the MAC list is doing. So when we say, we're going to reimburse you, I think your example was, it costs $100 it costs $105, but we're going to reimburse you $100. Was that what it was? Anyway, what we're trying to say is, we want you to buy these ones that are $50 or $25 so that you make profit. This one that was $105, don't buy that one. So your question was, one of the questions you had was, can you go to different wholesalers? And a lot of the pharmacies are locked into a certain wholesaler based on their contracts that they have. But what MAC is doing is not saying, I want you to go to a different wholesaler. It's saying, I want you to buy the version of Tylenol or acetaminophen that's made by a manufacturer that's charging a lower price. That's what we're trying to do with MAC. So anyhow, so the pharmacy audits,
Senator Bouchard.
Thank you, Mr. Chairman. I mean, and I just don't want to, I almost don't want to say this, but when we go into the hospital, the average cost for 1,000 milligram Tylenol is $46 for a pill. And I think the transparency thing that I want to know is, how much are you guys paying for that pill when we're paying a higher price? And so that comes back to where we're going with this whole thing here.
Mm-hmm.
So, I mean, would you be willing to tell us what you guys pay for that when they're charging $46?
so PBMs are not involved in hospital pharmacy. It's only outpatient pharmacies. So we're not in the hospital market at all. So I can't explain why they charge you $46 for Tylenol.
It still comes back though on even outpatient and things just like that.
Uh-huh.
We don't know where all of it's going. And then you've got the manufacturer who owns PBMs. You have the insurance company that owns, they do, but and so there's so many people involved. Everybody started buying up all these PBMs so they can control things. That's what I think that we're looking at here.
Right. Right. And so in that, MAC, in House Bill 35, what it says is we have to give pharmacists a way to look up what we're reimbursing. So if we're reimbursing the $10 for acetaminophen, or again, just pretend it's a prescription drug, they can log into our MAC website portal and see what we're reimbursing them for. So they have access to the MAC list sources. So what we don't have direct visibility into what a pharmacy is paying for their drugs. That's another important thing, is that I have no idea if someone is paying $15 for this or $10 for this. So what we have to do is get pricing information from national sources. We go to the wholesalers, we get information from NADAC, which is a pricing source that is mostly from independent pharmacies on a voluntary basis. We also buy we buy purchasing software at access to those prices. So we're looking at a multitude of sources that say, these are the prices that are available out there. And then we're setting the MAC rate based on what those sources are telling us is available for purchase. So there's that. Then there's the appeal process. So if we're reimbursing less than what they're paying, then the pharmacy can appeal to the PBM to say, you are only reimbursing me this, and this is what I paid. And then we can look at that and say, well, but it's because you bought this one. If you bought these two, then you would have made money. So there is that transparency so that they can see, what am I being reimbursed? And then they can appeal it and we can go from there.
Mr. Chairman,
Thank you, Mr. Chairman. So I think in the Texas model, the pricing schedules start becoming transparent. And
Yes.
that's what I think solves some of this for everybody.
Right. And I do have Texas and I did negotiate on that bill. So that bill was 4 years in the making. We started that bill in 2019, worked with the pharmacists to understand what the issues were, and then came up with a lot of the language that was there, and then it passed this session. There is a provision in there that says some of this stuff, some of the MAC transparency, but also any fees that you charge have to be outlined in the contract. And they are in the contract. So.
Representative Flitter, go ahead.
Thank you, Mr. Chairman. And thank you, Doctor. I appreciate the presentation. Since we're on appeals, you just noted that. Have you ever been involved in that appeal process? And what's the ratio in terms of pharmacies who have appealed to PMBs versus, ruling in their favor versus not?
So those are good questions. I would have to look that up because I didn't see the list of questions that LSO had. I was like trying to write them down. I'm like, okay, I can look into those. But there are appeals filed every day by pharmacies, either themselves or through those PSA or AO organizations. That's one of the services that they offer to pharmacies, is to handle their appeals to PBMs for reimbursement. So there are appeals happen every day. I would have to look to see the approval versus the denial. One of the other nuances in the House Bill 35 that you have is that if an appeal is made by a pharmacy and it's upheld, meaning that we find in their favor, yes, you were right, we're going to adjust it. It allows the pharmacy to reprocess that claim so they can get paid higher. But additionally, it goes a step further, and we as PBMs have to make that same adjustment for other similarly situated pharmacies. So any other pharmacy in the state that's in the same pharmacy network, we make those adjustments for them as well.
Go ahead and proceed, Doctor.
Sorry, I'm going to just write down your question on the percentages. So I will get you some information on that. Okay. So now if we can go to the next slide, this is Rutledge versus PCMA. This was the Supreme Cake Horse that has been talked about a little bit by everyone previously. So what Act 900 did was it established that the price that we would have, that PBMs would have to pay pharmacies, would be the invoice price. Which you're like, well, yeah, the invoice price. Except that if you look at even in the LSO brief, pharmacies negotiate with the drug makers or wholesalers drug costs, as well as discounts and rebates based on the volumes of drugs that the pharmacy purchases. So the issue that PCMA had with this law and why the suit happened was that the contention was, if we have to pay you the invoice price, that's actually different than your acquisition cost. That doesn't account for all of the post-invoice rebates that you're getting. That's additional savings that should be passed on to whoever the insured patient population of Arkansas. So that was the issue that PCMA, the suit was that it drives up the cost. And we want to make sure that we're accounting for all of these other rebates that are happening. So because it's going to lead to higher prices. If I have to reimburse you the invoice cost. So think about, I guess the way to think about it is the MSRP on a car. Yeah, that's your invoice cost, but who pays that? There's lots of stuff happening that brings that down, and which is great, fantastic. But those savings need to be passed on to the payers and the consumers. So that's where we struggled with this particular law. And I will say the Supreme Court said that rate regulation, so pardon me, requiring payment at a higher rate was not preempted by ERISA. So that is what the Supreme Court found, was that was the limit, what the limitation was of this case. They didn't say, and I'll get into it in the next slide, they didn't say, you can regulate anything and anything that PBMs do. And in fact, the Supreme Court acknowledged in their decision that this could lead to higher drug prices. And in fact, one of the justices wrote that if you adopt this process or this policy, it could mean that a plan in Arkansas is going to pay more for prescription drugs, for the same prescription drugs, than in another state, such as Arizona. So, so the next slide, if we can go, has a little bit more on the Rutledge. I'm not going to go through the big four, but again, it's just trying to present what Rutledge was. It didn't say that they could regulate PBMs, every aspect of what we do. That didn't say that this was good policy. And it didn't say that every law directed at PBMs is valid or not preempted by ERISA. There are still things that we do that are preempted by ERISA. But the bottom line is this: Arkansas, Wyoming, all states can pass laws that set rates for what we pay pharmacy providers, but know that that will lead to higher costs that you are paying for either for the prescription drug directly or for your healthcare insurance. So we really want to make certain that that's understood, that it will increase costs. So we can go to the next slide. So these are just to wrap up the key takeaways about PBMs, and payers choose to contract with us. They can do it themselves, but they generally use us because of the expertise that we have and the ability to negotiate on a much larger scale for better cost savings. We work for those payers. That's who we work for. A lot of people ask, well, who are your clients and what do you do and how do you work for them? We leverage competition and supply chain to obtain those lower prescription drug prices, whether it's negotiating with the drug manufacturers or negotiating with the pharmacies on what they charge for their services and medicines. Payers always have the final say when they contract with us. So I know there was some discussion about spread pricing or pass-through pricing versus spread pricing is used in two different contexts, but the way that the payers contract with us, they make that decision. And we generally want them to have the ability to choose whichever way is the right method for them. And then finally, payers retain full audit rights to PBMs. So they just, Blue Cross Blue Shield of Wyoming and Blue Cross Blue Shield of Texas audit Prime all the time to make sure that we are delivering the services that are that we've contracted to deliver at the prices that we've contracted to deliver. So that is the presentation, but I did want to, if I could, address some of the questions that were brought up earlier, or Mr. Chairman, we can do open.
You go ahead and answer some of the questions. I bet there might be more questions coming, so go ahead.
Okay. Let's see. Trying to find the ones that I think the one that was intriguing to me was from Dr. Hallinan, Mr. Chairman, was, do we really provide value and cost savings? And is there any proof of that? So one of the things that was passed 2 years ago in the state of Texas was a drug price transparency bill. And that required manufacturers as well as insurers and PBMs to report different things to the Department of Insurance. The first report came out, probably a month ago. And what it showed was, because it was a lot of the same questions. What do you do? Do you really deliver these cost savings that you say you deliver, because we don't know that you do. And so in that report for 2020, the PBMs that are registered in Texas that reported to the Department of Insurance showed that we delivered 2.3 billion with a B dollars in savings to Texas insurers in 2020. Of that 2.3 billion, 1.8 billion went to Texas insurers. So we are delivering the savings that we say that we can and do. And again, it's difficult because the insurers are very sophisticated healthcare purchasers. They wouldn't contract with us if we weren't delivering a value or delivering cost savings. So, sorry. That was the Texas Transparency Bill. And then Representative Flitner, I think, okay, sorry, I was sitting in the corner, so I couldn't quite. You had talked about cash price versus insurance pricing and what PBMs do. And so PBMs, because we work for payers, we're not necessarily we don't necessarily impact cash prices because we're working on behalf of third-party payers, so insurers, government entities of that nature. But I will say that another piece of legislation that Texas entered in, actually passed, was a Texas Uninsured Texans Act. And in that, PBMs are an integral part of trying to see if there's a way that they can provide, that PBMs can help provide the cost savings that we negotiate to the uninsured market in Texas. So it's still it's a policy concept. The next steps is for us to have, a gathering of all the minds to see how this can happen. But it is kind of the first kind of proof of concept to see what can we leverage what PBMs do in the uninsured market. So.
Okay, with that, questions committee. Representative Stivar.
Thank you, Mr. Chairman. How do I want to put this? And I think it needs to be stated. Is Big Pharma the one that sets the prices for all medication?
Yes, sir.
That just, all right. Thank you.
That will qualify as quickest question and quickest answer of the day. Further questions, committee. Representative Wharf, long time no here. Go ahead, sir.
Thank you, Mr. Chairman. I finally got a question. I was wondering, sounds like you had some involvement with the Texas law.
Yes, sir.
In your opinion, do you think that made it better in Texas for the consumers or the payers?
Go ahead, doctor.
So I had some concerns as a pharmacist about the provisions where we as PBMs could not require accreditation of specialty pharmacies. And let me just kind of explain that. As a pharmacist, I have a license as a pharmacist. I can dispense any medication. But these specialty drugs that are, hundreds of thousands of dollars, they're generally dispensed by these specialty pharmacies, not only because they're dispensing here's your medicine, but they're also coordinating all the care around that. They're helping the patients get through prior authorizations, going to different foundations to pay for that $83,000 medication. They're, organizing, getting nurses to give you that infusion in your home. So there's a lot of services that the specialty pharmacies provide in addition to that. And accreditation is something, from my perspective, as a former Board of Pharmacy member, accreditation is a way for a PBM for a pharmacy to say, I'm accredited, so I have all the systems in place to deliver all of these specialized services consistently and at a high quality level to these patients, whether I'm giving them an MS drug or a rheumatoid arthritis drug or a cancer drug or infertility drug. I have the systems in place to get it to them safely. I have the expertise. My pharmacists know hemophilia and how you treat it and the nuances of that treatment. So from my perspective, that was one of the concerns that I had about I thought that was something that it undermined a little bit of the patient protections that I personally like to see. But there were other things. Again, part of the discussion with the Texas plan, again, the state of Texas was Representative Alderson brought everyone, all the stakeholders together so we could hear, what are your issues? And then we could go back and say, who's doing that? How does that work? How do we fix it? And so a lot of the language that's in that Texas bill was language that we developed together to come up with. And that's why no one opposed the bill. The Senate and the House voted unanimously. But that's because it was, we had lots of stakeholders coming together to get to policies that were fixing the problems that we were trying to fix. It wasn't just roughshod. It was like, okay, you have this issue. How do we fix it?
Yeah. Follow up, Mr. Chair.
Follow up, Representative Wolf.
Okay, so based on your testimony, I'm assuming that that's a yes, that you felt it did make it better and that you were able to get everybody together and talk about how it needed to be fixed. A follow-up question to that would be, then based on what you said in your testimony, I'm assuming that the thing that you felt was lacking was the specialty medicines, the ability. You didn't feel like the Texas law addressed that? Is that
It
correct to
prohibited
say?
us from requiring accreditation, which is that patient safety protection that we have in other states. Now we won't have in Texas.
Okay. But you also felt like the kind of the specialty medicines weren't addressed in the Texas law? Is that accurate?
I remind you guys, make sure and go through the chair so we can just kind
Oh,
of
I'm
keep
so
it under
sorry.
control. You're fine.
Chairman Baldwin and Representative Worf, can you restate your question?
Yes, Mr. Chairman.
Go ahead.
Well, the question I'm asking is, in your testimony, it sounded like that was one thing you didn't feel like the Texas law addressed enough was kind of the specialty medicines. Like you mentioned some of the stuff that almost is proprietary to the manufacturer, that maybe those medicines weren't necessarily addressed as well as the MAC stuff that's more the generic type. So would that be a way that you would say that you can improve the Texas legislation? That's what I'm trying to get at, is how you would improve it.
Okay, so Chairman Baldwin
Go ahead.
and Representative Worth, thank you for clarifying that. We very much engaged with them, with the Texas legislators, and tried to explain the importance of accreditation and why we had that as a requirement. That is something that, if I could wave my magic wand, we could revisit, because I think that's a really important patient protection that was prohibited from happening.
Dr. Representative Hallinan, go ahead. You've been waiting patiently.
Thank you, Mr. Chairman. My question is, I believe that Wyoming Medicaid does not use the PBMs to price their drugs. They buy theirs without the PBMs. And so why is that? If they can save that much money in Texas by using the PBMs, how come the Wyoming Department of Health does not use a PBMs to buy their drugs for Medicaid patients? Thank you, Mr. Chairman.
So
Right, Doctor.
Chairman Baldwin and Representative Hallinan. So as I stated, payers choose to contract with a PBM. If they feel that they can do it themselves, then they can do that in-house themselves. So I don't know for certain if Wyoming Medicaid does or does not use a PBM. I will make that assumption. So it sounds to me like the entity that runs your Medicaid program has decided that they can do that better than a PBM, completely within their rights to do that.
Follow up. Go ahead, Dr. Hallinan.
That's not necessarily my question. I know that that's possible that they could do that. But why do they believe that they can do that cheaper? I would want to know why that would be. If they make that, they save that much money in that Texas study that you have, why can't Wyoming Medicaid also save money? Now, maybe they don't, maybe they have some doubts about that Texas report. Thank you, Mr. Chairman.
Thank you. And I might suggest that probably we don't have all the right people here to answer that. But Chairman Wilson has a comment.
Yeah, Mr. Chairman, thank you. Actually, Wyoming Medicaid, I believe, does purchase through a multi-state compact.
And I believe that that's true because I know I get things back on my Medicaid patients with preferred drugs, et cetera. And it's, we won't talk about my pet peeves with that right now, but I believe you're right. I believe it's a multi-compact. I agree. Okay, Senator Bouchard, I believe, has been waiting the longest down there next. Go ahead.
Thank you, Mr. Chairman. I want to go back to the Texas model with the specialty drugs. Would that even affect Wyoming? Do we have that same network here? I mean, because I picture that as say a cancer center in Texas, maybe a bigger provider network, maybe bigger population. So would that even be different? Maybe different than Wyoming. I mean, so I want to come back to the Texas legislation. What would be the big red flag not to do it here? And is there specifically that same specialty drug problem here in Wyoming?
Chairman Baldwin.
Go ahead,
and
Doctor.
Senator Bouchard. There are specialty drugs that are dispensed to patients here in Wyoming. So that would exist in the state of Wyoming.
Follow up.
Quick follow-up. Well, yeah, from what I understood, it was a specialty drug and then all of the components were connected to that. So, I mean, that's what I'm asking, because I think if I look at the cancer center in Cheyenne, I'm just wondering, is it the same model? I mean, would they be handling some of those components themselves and not have to rely on the same network, whereas you had the objection in the Texas model because it was specific to Texas? We don't have very many cancer centers in Wyoming. So that's where I'm trying to nail this down. Do we have those same objections that you would have had in Texas? I'm not saying that there's not specialty drugs being dispatched, but I'm saying, is the model the same? And because I mean, I can't see it in such a small population state.
Chairman Baldwin and Senator Bouchard. Trying to figure out how to answer because in the state of Wyoming, you're going to have patients who have hemophilia or have multiple sclerosis or cancer. And so they would access those medicines, those specialty medicines from specialty pharmacies that are able to offer not just the product, but also all of the supporting services that ensure the best use of that medicine.
I'm going to turn my head the other way for a moment. Senator Hutchins on the end. Go ahead, man.
I believe Representative or Chairman Wilson was before me. Are you?
You've got the mic. Go ahead.
Okay. Thank you, Mr. Chairman. Ms. Lugina, we heard earlier that the prices of drugs have skyrocketed. And we kind of heard that it's because of the PBMs. You come and you say you're doing all these nice things and the prices of drugs are going down, but they're not. Can you explain to us the disconnect? Why prices are skyrocketing with your assistance? And would we be better off in Wyoming to just totally take the PBM out of the picture and possibly get our drug costs down? Thank you, Mr. Chairman.
Chairman Baldwin
Go ahead.
and Senator Hutchins. First, I want to say thank you for saying my name correctly. That's quite the achievement. So I appreciate that. So to answer your question, the price of a drug is not set by a PBM. It is set by the manufacturer. What we are doing is negotiating with those manufacturers to sell it, to get a reduced cost for that. So the list price is $200. We go to them and say, I have all of these patients that I can bring to you. What will you give me as a discount off of that $100? So the fact that drug prices are skyrocketing is because of the drug manufacturers. They set those prices. What we're doing we're the only entity in the drug supply chain that's negotiating to bring the cost of medicines down. So that means what are you as the insurer or the payer paying for that drug? So you're not paying that $1,000 for the Hep C drug, you're paying $589 because we've come to you and said, we're going to be able to drive, we have this many thousands of lives that will direct to use your drug instead of the other two that are on the market. And you've given us that difference, that savings from the $1,000 to the $589.
Just
Follow up, go ahead.
follow up. Thank you, Mr. Chairman. I got all that.
Mhm.
But in reality, the prices are still high. So if it's only the drug manufacturer that's setting the price, then we just wasted 5 hours of time. Is that correct? In
Go ahead.
reality.
Chairman
Have we-
Baldwin
Go ahead, Doc.
and Senator Hutchings. That's part of the drug supply chain. You have to look at the entire system, and we've had different states that have entered into that. Just like I talked about Texas, or some of the other states have done that as well, where there's some accountability for the manufacturers, the insurers, the PBMs, all to report to this, usually it's the State Department of Insurance. What are you charging and where's all this money going? How do we do this? Where is this? How do we make this better? So that's the first part, is you have to look at the every single cog in the wheel. So no, hopefully this isn't 5 hours wasted. It is a I would say that the problem is that you probably need 5 hours times 17 to understand. And again, that was one of my challenges with this presentation, where I was just like, this is like asking me asking you, how do you ranch? Tell me about ranching. I'm like, what do you want to know? So again, it's hard to understand, but again, as a PBM, our goal is to try. If you can't access if it's not affordable, then you can't access it and you can't get the benefit from that medicine. So anything that we can do to bring that $1,000 down so that it's more affordable and accessible, and then you can access it and take it and get that cure.
Gotcha. One, and I'll shut up just after
You
this
don't have
one,
to shut
real
up, but
quick.
Go ahead with the
Thank
follow-up.
you. So would it help the consumer to know the prices of everything up front? So I can say, I'm gonna come in and I see the dollar store price, the Walmart, the different store prices,
Pharmacies.
the manufacturing prices, out of the 4 bottles there. I can see that myself. Would that be a benefit to everybody?
Chairperson Baldwin
Go ahead.
and Senator Hutchings. Someday I'm gonna not have to look at your name tag. So yeah, I both and again, here's the thing that's so hard about to get your head around with drug prices. Yes, from a consumer's perspective, that would be helpful. But remember, drugs are also there's 2 people paying for a drug, the consumer
Right.
and then the insurer or payer. So when you go so for example, I just got a prescription for my son and I paid a $50 copay. But on the receipt, it said, oh yeah, you paid $50, but the total cost of the drug was $1,000. So that insurer is paying, my insurance company is paying that difference. So again, that's another, it's so complicated because it's not just I'm a consumer and I am paying 100% of the cost for that drug. You have multiple payers that are in this, that are paying for that. And that, yes, so yes, it would help a consumer, but it also helps the payer. It needs to be bigger than that.
Very transparent. Thank you, Mr. Chairman.
Thank you, Senator Hutchins. Well, we got one next to you first, Chairman. Go ahead, Representative Valero Martinez, go ahead. You're not ready? Okay, Chairman Wilson, go ahead.
Thank you, Mr. Chairman. So I think, and I think I can turn this into a question at the end, but one of the problems that I see is, you know, we're trying to squeeze the healthcare water balloon. And every time you squeeze one part of the healthcare water balloon, it bulges out someplace else. And if you think about what we've done since the mid-'80s, say, in healthcare, almost nobody is dumb enough to pay the invoice price for anything anymore.
Right.
Medicare doesn't look at the hospital and say, oh, well, there's your invoice, $30,000, I'll pay that. They don't. Medicaid doesn't pay the invoice price. TRICARE doesn't pay the invoice price. There's only a few foolish people who are paying invoice price from the hospital. Same thing with the doctors. And so then those healthcare providers have to figure out some other way to, you know, whether the doctor's going to buy a CAT scan machine and order more CAT scans or something. And so then we just run around trying to figure out a way to, you know, squeeze that part of the water balloon back in the other direction. So it seems, you know, in pharmacy, if we mandate as the legislature that now in this particular category, the payer has to pay invoice price, but we're not doing that for doctors' offices. We're not doing that for physical therapy. We're not doing that for hospitals. You know, the problem here really, I mean, in a way is that we have left pharmacy because of the way things are structured. They have run out of places to make up the difference. You know, I mean, they've come to us before asking, can we bill Medicaid for our clinical services? You know, doctors can, I mean, that they don't have as many ways to make up the squeeze as other parts of the healthcare sector. You know, we have hospitals coming to us asking us to expand Medicaid, doctors, I mean, everybody is trying to find another source of payment because the cost of healthcare overall is going up, and we keep trying to reduce the cost while still having high quality care for everybody at a low price. And you can't add those three things together and have them work. So what we need to try to figure out is a way, you know, I mean, and we're not really going to squeeze the water balloon all the way up to the big pharma and say, hey, Vladimir Lenin says you're going to give us your drugs for cheap.
Right.
I mean, that's not the answer in America. And it's not going to give us the drugs that we want either. The question is, what is the best way to make everybody a little bit more whole? The consumer a little bit more whole, the pharmacists a little bit more whole, so that people still have services. Do you have any thoughts on that?
Well done. Well done. Go ahead, doctor.
So I'm not, do I just have to go through
Yeah,
Chairman
go. I
Baldwin
gave you
and
permission. Go.
Madam Chairman Wilson? Absolutely. It would, what we did with the 2013 legislation and what we would propose now is the same solution. Let's sit around. What are the issues? Let's talk through the people who know it. Like, you know, the pharmacist and I can talk and we speak the same language. You know, we can start using all these acronyms that you guys would be like, what? But what's the problem we're trying to solve? Let's validate it's happening, where it's happening, and can we fix it at the state level? That's what we did in Texas. We've done that here in Wyoming. We could do that again. So absolutely, I would support that concept.
Thank you, doctor. I got to admit to the committee and to the audience here, I have two thoughts in my mind right now. One is I got the water. I have a red water balloon. I don't know if that's color it was. I want to take a pin to it really bad. That's a juvenile delinquent to me. I want to pop the balloon and then we don't have any water. You can squeeze it all you want, but that's not serious.
Yeah.
Serious aside, what's in my mind, and I think we just sort of spoke to that, is in we've done it with this topic actually, and in this committee before. We formed working groups. And I have people in mind that I would like to be on that working group. I won't share them now because one of them is out of the room. But I think it's going to be worthwhile to form a working group, which we can do without a lot of approval and a lot of red tape, and get all the parties together as you're speaking from Texas, and get everybody together and come back to this committee in September, put them on the agenda, and bring us some suggestions, some alternatives, ranging from one side of the spectrum to the other. But those are two thoughts that are on my mind, and we won't decide that right now. Let's not pop the balloon either. Let's go ahead if there's more questions. Oh, we'll go to this side for a minute. We'll come back to that side in a minute. Go ahead, Representative Conley. You've been waiting patiently.
Thank you, Mr. Chairman. And before I start, I just want to understand, Dr. Mendez Harper, are you a local pharmacy? Are you a local, do you run a local pharmacy here, or are you representing a national PMP?
Chairman Baldwin and Representative Conley, I am a pharmacist. I work for Prime Therapeutics, which is a PBM that's owned by 18 Blue Cross Blue Shield associations. So I was here to just explain prescription drug costs and PBMs kind of globally.
So thank you, Mr. Chairman, and thank you, Doctor. At one point, I thought you said that you were a pharmacist, and I thought there was the implication that you were working here, but that's not the case. You are representing the PBM, Blue Cross Blue Shield. Got it. Okay. But ultimately, so now I'm going to switch to my question, which will have two parts to it. My interest in this topic is to assure that Wyoming residents get the medications they need at reasonable costs, right? That's my overall interest and goal. And so I'm curious on one end, and actually this follows up from Representative Flitner's question about uninsured patients, and curious, and here in Wyoming, we don't, and I'll say yet, hopefully, that we don't yet have Medicaid expansion. We have tens of thousands of individuals who do not have insurance coverage. And I'm curious what you are doing, what your I'm going to get your acronym,
PBM.
yes, your PBM is doing to, get for me that ultimate goal. Our residents get the drugs they need at affordable costs. So can you answer that part?
Absolutely. Chairman Baldwin and Representative Conley. So this gets to who do we work for? A PBM works for a payer. So that's why we traditionally don't have a footprint in the uninsured market. Because we're hired by payers to bring down the costs. What Texas did in passing that uninsured legislation earlier this year is they came to us and they're like, can you fund this? And we were like, no, you have to have a payer, like somebody. And so the state of Texas is the payer to help, and they're using our tools so that because a uninsured patient in that example with $1,000 per pill drug, they're paying $1,000 right now today. If it was still $1,000, they don't get that benefit of that $589 drop. But what the uninsured plan in Texas is trying to do is say, we're going to be the payer, but we want you to use your tools and have you negotiate to hopefully bring that price down for our uninsured patient population. So it's a new concept, again, because we're hired by payers. And so in an uninsured patient population, the payer is that individual.
So, Mr. Chairman, just to follow up, so then in what, do we need legislation in Wyoming in order to do something comparable here? I mean, you keep on talking about Texas. Is there anything that you're doing in Wyoming? And if the answer is no, is legislation needed in order to do it?
Chairman Baldwin and Representative Conley, it's something that you could consider. I mean, it was a way, there's Medicaid expansion, and then this is a new concept. Again, we're still trying to get through the whole proof of concept. We're supposed to have, bring everybody together, just like we're proposing here, to understand like, how does this work and how do we deliver this program that conceptually makes sense? But now we need, the rubber meets the road and we've got to figure out how it's going to actually work. So that's the next step for that legislation.
Mr. Chairman, one more.
Okay.
Okay, thank you. And that this one here, and again, it goes to my interest, and I think this committee's is, again, it's about the people in Wyoming. And ultimately, when I was out to lunch, it occurred to me, I don't want to choose between what private company is going to make the most profit. Is it going to be a PBM with the name of Blue Cross Blue Shield, or is it going to be a Kroger or a Walgreens? I don't think that's our interest ultimately, is to get involved in that. However, that being said, I am curious, and I would ask the same to Dr. Culler, how much profit is your company making right now and in comparison to what it did 10 years ago? Because it certainly was implied that it's astronomical, and that was never the design. And I'll ask the same to the private pharmacists as well.
Chairperson Baldwin and Representative Conley. So Prime is owned, as I said, owned by the Blue Cross Blue Shields plans. So we're not, all of our profit or any money that we make, it goes back to our blue plans. So I can't answer that question because we have a different ownership structure. We're not like a private company that contracts. We're owned by the Blues. So everything goes back to them.
Thank you, Mr. Chair. And could you get that for us when we sit down again? I think you can. I mean, you're a profit-making company. Somebody, we can go and get your bottom lines.
I would suggest, Representative, that that's something they can bring to the working group. And that's something that can be discussed at the working group. Blue Cross Blue Shields can certainly bring that, whatever they can obtain, bring that back to us. That being said, further questions, committee. Representative Romero Martinez, you're ready.
Thank you, Chairman Baldwin. I'm just going to start with a little bit of a background. In a 2019 article in the Washington Post, just to kind of give a background, each year brings a fresh episode of popular political outrage over high drug prices. In 2019, it was insulin's turn in the spotlight. The life-saving drug for diabetics surged in list price over 250% over a recent 10-year span. And so just a little bit of a background. I think we all pretty much spent the last 5.5 hours. It was in good use, and we probably need another 100 hours for a working group, and that's fine. But the general consensus is that medicine costs too much. We have a healthcare price issue. We have multi-trillion-dollar and billion-dollar corporations, and they're always going to tell you that they have the prettiest roses and they're giving you the best price. But those are lies. The balloon can't be squeezed back and forth over and over, and we don't want to pop it for sure. I guess I'll be really interested in the last question. I almost don't want to say too much, but my question would be, if there's the $1,000 pill or what to the $589, it looks like the pharmacy still purchased that drug at $1,000. Is the PBM pocketing the rest?
Chairman Wilson.
Wilson, yes. Go ahead.
And Representative Romero.
Yeah, holding.
No.
So I guess the question was,
Are we,
the pharmacy manufacturer is making $400 and something less on their pill. Is that the sum of it?
Chairman Wilson, yes.
Well, thank you for answering that question. I don't really think I have a follow-up. I guess my comment, and I could be wrong here, so correct me where I'm wrong, anyone, but it sounds to me like there's just a disparity. There's a disparity at the level of the PBM, and there's also a disparity at the level of the big pharmaceutical / manufacturer. And I look forward to helping find a solution with the needle in the haystack going on here. Thank you.
So just remember, we don't have anyone from any pharmaceutical manufacturer here. Representative Ottman.
Thank you, Madam Chairman. I have two questions. Actually, what I was wondering, and the first one would be the insurers that you work for. Are there contracts to where they are required to stay with you for so long, or that they can only deal with you? And how do you get reimbursed for your services? Okay, so that's one. The second one is, if you could, because I still, being new to this whole concept, I would kind of like if you could just give me an idea of a flow chart of how it goes from the patient and their insurer to where they get the pharmaceuticals, to where it's paid for. And then if there's a discount, how that goes backwards. So that it just doesn't, I've never had my insurance company call me up and say, hey, we got a discount on your pharmaceuticals because there was a lower price, blah, blah, blah. And so we're going to send you a check. So I was just wondering how it goes up and how it goes back. And it doesn't have to be real lengthy, but I was just wondering if you could kind of give me that synopsis. Thank you.
And before she answers, just remember that, so this particular witnesses work for a company that is owned by Blue Cross Blue Shield, which is, and I believe, a nonprofit corporation. So they are not, so there are other insurers that are for-profit companies. Blue Cross Blue Shield is a special case of a kind of insurer. So go ahead. I just want to remember that we have one of a multitude of kinds of companies here. Go ahead.
Chairperson Wilson and Representative Ottman, I was writing down what you were asking, so I made sure I answered it. So the first part of your question was about contract terms. Generally, again, it's different. It's unique for me because I'm owned by Blue Cross Blue Shield of Wyoming. So we're their PBM, but my understanding with other PBMs is there's generally a term of service that the payer contracts with the PBM to provide services. So generally it's like 3 years, and then they'll go out and rebid for the business again and have other PBMs competitively bid for it. How we're paid. So that was touched upon in the LSO document and the Department of Insurance as well. But so the two extremes of how a PBM is paid is either fees, so the administrative fees, or keeping a portion of the rebates that we negotiate from the manufacturers. Those are like the two extremes. And then there's there's hybrids in between. So how am I as a PBM paid? In my case, is we're all fee-based. So any rebates that we negotiate from from the manufacturers, 100% of that goes back to my client, who's Blue Cross Blue Shield of Wyoming. They use that. They would have to answer how they use that, but generally it's used for the collective to decrease the cost of care for everyone. The other extreme is, for the other PBMs, is that they'll keep a portion of the rebates and then they won't charge fees. So that's how that works. It's like generally it's one or the other. There can't, again, there's nuances always, but that's generally how it works. And then let me see, flow chart of patient and insurance. So that was the chart, like slide number 3 or 4, that has the flow of drugs and then the flow of payment. Sorry, slide, the drug supply chain complexities. And can you remind me, I just wrote down a flow chart, but I didn't write down what the question was. I apologize.
Representative
Chairman.
Oppen, you want to restate that?
Madam Chairman, yes, I guess I understand how it goes up, you know, and how things are looked at. But we heard testimony earlier that said that sometimes there is a price for a drug or whatever it is. And that would be to the pharmacy. And then there is maybe a lowering because there's a time period. And I'm not sure what that time period is. If there was a week thing in there and different things like that. So if there is a new price on something, how does all that work? I mean, how is everybody notified? Because we heard that, well, we had an invoice of this, and so we charged this, and then we heard that there was a lesser price, and that was what was going to be paid on. And so I was just wondering how things went up and how things went down and how all that communication amongst millions of people and lots of companies goes.
Right.
Okay, thank you.
Madam Chairperson Wilson and Representative Ottman. That is part of the MAC law that for the generics, for the MAC law, that's where you have that portal where the pharmacies can get in there and see what the MAC price is for a specific drug. And that's updated every 7 days, so that we're able to make adjustments for, you know, in the case of, I think somebody was talking about dexamethasone earlier, where that price fluctuated greatly during the pandemic. And so every 7 days, we're updating that price to reflect where those prices are at nationally.
Follow up, please. And I'm sorry, I might just be thick on this. Okay, so as those prices are adjusted, if you've already paid for that and then the MAC price is lower, how does that work?
Chairman Wilson and Representative Ottman. In pharmacy, claims are adjudicated real time. So when the pharmacist is filling the prescription for you and you're coming in, they're submitting that claim to us right then and there. And that's when we're telling them what the reimbursement is for that medication.
Senator Furphy, go ahead, sir.
Thank you, Mr. Chairman. Of course, the real issue is high drug prices that we're trying to get to. And obviously, your testimony and others, they've skyrocketed. Vermont, Florida, and Colorado are forming a coalition to import drugs from Canada to try to put pressure to make US drug companies more competitive. Interested in your thoughts on that, if Wyoming should maybe be part of that same coalition. Thank you.
Go ahead, Doctor.
Chairperson Baldwin and Senator Furphy. That's a policy decision that is well beyond a PBM and what we do. I have worked on legislation for importation. There are some considerations that need to be made, primarily that Canada can't supply the entire United States medications. But that's kind of a bigger policy discussion than just the PBMs. You'd have to get the insurers and the pharmacies and everyone and the wholesalers, because the wholesalers are usually importing from Canada. So it's a much bigger discussion.
And I would add on to that, Senator Furphy, that is a process that is underway, actually, which we already addressed. We could address that in a separate meeting or off state sometime, but it is being worked on. Further questions, committee? Blank stares. One more. Senator Hudson's got her hand up.
I don't know if this is a question, Mr. Chairman, or just maybe a comment. Maybe Miss Lugina can give me her thought on it. In our free market society, if I make something, I spend my time, my money, my energy creating something that you want, And we all know that that could be expensive. The clinical trials we talked about earlier, testing, all the stuff that's involved there. So I make something, a drug, that is just awesome. It'll cure death. And now everybody wants it. I should be able to charge what I want. And we all know that. But somehow we have this thought that the government or the state can come in and say, whoa, stop, you can't charge me that much. Everybody in the world should be able to access that. Really? Well, if they pay me, they can access that. And we all know that in reality. So my question and thought is that the government and the state have gotten so involved in this medical process. We've gotten away from the day when the doctor would come to your house, you'd give him a dozen eggs and he would look at all the kids in the house and move on, to where prices are astronomical. Somehow, some way, and tell me if I'm right or wrong here, between my product and the pharmacist getting that product to give to the patient, we have somehow inserted the PBM, and they're skimming their portion, and it's just kind of thrown a monkey wrench into the spoke. Am I on the right track or not?
Chairman Baldwin and Senator Hutchings, everyone in the drug supply chain is I don't want to say skimming, but like there's, you know, whether it's you have the manufacturer, but you have the wholesalers, you have PBMs, you have pharmacies, you have, they're all providing a service, and they are all getting compensated for that. And that's part of the overall costs.
Thank you. Further questions, committee? I believe we're going to let you off the hot seat. That literally is the hot seat today. Beware if you come down and sit there, it's a difficult one to get out of. And I would remind the committee, we've heard a lot of questions and we've answered a lot of questions and we've made a lot of questions that will potentially be answered in a, I'll say it again, working group. That being said, I was going to ask another survey question that I said this morning, and that was because I suspect we'll get more hands raised. How many people in the audience know what amlodipine is? I like that.
There's more now.
Much better. There will be a quiz at the end of today's meeting.
You have to draw the chemical picture of it.
Sure, I can do that. Okay, we'll open this back up for more public comments. Is there anyone else out here that wishes to come up and speak? How about you? That's a good idea. Chairman Wilson brought up a good point. Anybody that remains that wants to testify, come on down and sit in the seats, and that'll give us an idea of how many folks we got left. And if there's not enough seats, get as close as you can.
Mr. Chairman.
It's like the voice.
I know.
Sorry, go ahead, Mr. Brody.
I just wanted to let the chairman know, let the committee know that there are also 3 individuals online that are hoping to provide testimony.
Very good. Well, we'll get to them, I promise. Okay. Go ahead and turn your mic on, introduce yourself, and go ahead and tell us what's on your mind.
All right. Mr. Chairman, my name is Camilla Hancock. I am a doctorate of pharmacy, and I am here trying to help represent the independent pharmacies here in Wyoming. I'm going to let you know here, I'm kind of setting the stage for the Zoom testifiers as well. And so just so you know, that's what I'm kind of setting up here. To begin my comments, I would like each of you to take a moment to imagine that you are a cattle rancher. Some of you may not need to imagine this, but think you've raised 10 calves and you're going to take them to auction, and you feel confident that you're going to be able to get a good price on them. Based on your calculations, you decide that you need $1,500 a head to break even. You are confident that you'll get more because your cows are healthy and it's a good market. However, when you get to the sale, you are informed that you will only be getting $1,500 a head, no more. You are disappointed, but you at least break even, so you agree to the terms. As the cows are loaded and taken to the buyer, you hear the auctioneer on the phone speaking with the buyer, and he tells them that the cattle have been sold for $1,700 a head. You are upset and frustrated, but the deal's been struck and your cows are already gone, so you feel you have nothing else to say. The next week, you get a bill from the auctioneer who explains that during transport after the sale, your cows lost 10 pounds each, and the auctioneer, is charging you $10 for every pound lost. Finally, 3 months later, you get another bill from the auction service, this time telling you you owe them $100 because you failed to print your name above the signature line on the sale agreement. When all is said and done, you've lost $1,100 on the deal. This scenario is frustrating and, to be honest, sounds rather ridiculous, but it is something that independent pharmacies face every single day. Pharmacy benefit managers, or PBMs, are like the auctioneer. They are the middleman. They facilitate the interactions between pharmacies and the insurance companies. Their intent at first was good. They were made to save money on prescription drug costs. But they have gone unchecked for too long and have become large multi-billion-dollar companies who are driving independent pharmacies out of business and increasing patient costs. How are they doing this? Well, if you take a look at this first page that I've given you, and it's similar to what you've seen already, but you'll see the PBMs are located here. They are contracted, as we've heard already, by the insurance companies to create their drug formularies, or the list of drugs that the insurance company will pay for. Then they work with drug companies who will bid against one another for a place on the drugs on the PBM's formulary. They do this by offering rebates. Pharmacies then pay the PBMs for the opportunity to be on their pharmacy network, meaning a pharmacy that the insurance company will pay. If you're not on the network, they won't pay you. Then when a pharmacy files a claim, the PBM will tell the pharmacy how much to charge the patient. And then they pass the bill to the insurance company, who will pay the pharmacy what they were told it costs. It sounds reasonable, but this is where PBMs get shady. First, in order to provide the best rebate to the PBM, drug manufacturers will raise their prices. These bigger rebates are then passed to the PBMs. And you can find evidence of this on that next page. I have an article from Inside Drug Pricing where a drug in Breja, they talk about their sit down with PBMs and how they were told they had to have a higher price than what they wanted in order to provide the PBM with the expected rebate. Second, PBMs practice something called spread pricing, and this is where, like the auctioneer, they tell the pharmacies that they will get $10 and then turn around and charge the buyer or the insurance company the $15, where they pocket the difference. Third, PBMs charge DIR fees. These fees are charged for not reaching those always changing goals or requirements. This would be similar to being charged for every pound your cattle lost in transfer. Fourth, PBMs will claw back money after the sale has been completed. This can be done by telling the pharmacies the copay for the patient will be higher than the cash price for the drug. Then at a later date, they will claw back the overpayment to the pharmacy, much like the charge for not printing your name above the signature line. Just like the charge for not printing your name above, just as the cattle rancher lost money, pharmacies are losing money. The amount of DIR fees is increasing astronomically. In fact, it has increased by 91,500%. And I know you heard this already, but I still like saying it because it's such a good visual. You'd go to the grocery store today and you would buy a gallon of milk for $3,660. I couldn't afford that, could you? When pharmacies are being under reimbursed for prescriptions, not only are we losing money on the drug itself, we are losing money on the dispensing as well. On average, in 2018, it was found that the cost for dispensing was $12.40 per script. With numbers like this, it's a miracle that any of us are open. But I promise you, if changes are not enforced and made in the Wyoming law, we won't stay open. We are already on a negative trend. In fact, PCMA released a report and it showed that Wyoming is in the negative for independent pharmacies. And I have an article here about Buy Right Drug out of Casper, an independent that went out of business as well. And this is going to continue to happen to pharmacies in Wyoming if this trend continues. So you may be asking yourself, if these problems are true, why aren't all pharmacies banging on your door? Well, PBMs were smart and they started buying their own insurance companies and pharmacies, effectively creating this vast vertical integration, which strives to put independent pharmacies out of business. And how do they do that? They do it by paying their own pharmacies more than other pharmacies. And if you look at the stat article with the logo on the front, it talks about and gives evidence of this. They also do it by forcing people who use their insurance plans to use their mail order pharmacies. I have not put a dent into the injustices that independent pharmacies have experienced at the hands of PBMs, but I do want to leave time for the other testimonies that I referenced are coming. I, however, want to leave you with this thought. How healthy are you? How healthy is your mother? Are you healthy enough to wait 48 hours for your mail order antibiotics to come? Is your mother healthy enough to drive 4 hours to the nearest chain pharmacy? Are you healthy enough to wait for large out-of-state corporations with their multi-billion-dollar income to suddenly have a change of heart and take pity on rural communities in Wyoming? I doubt we are. I do, however, know that your local pharmacies and your local pharmacist does care about you. They care very deeply about you. They care about you, they care about your mother, and they care about that rancher that just lost at the sale. Thank you, Mr. Chairman.
Thank you. Questions, committee? Go ahead, Chairman Wilson.
Thank you, Mr. Chairman. Thanks very much. And thanks for the services that you're providing.
Thank you.
The question I have, and I remember from this morning, I believe we heard that there are 118 retail pharmacies in Wyoming. I think I have that number right. How many of those are owned by, so I'm reading from this article about pharmacies owned by PBMs. So do you know how many of the pharmacies in Wyoming are pharmacies that are owned by PBMs?
I don't know exactly. I know that 44 of those pharmacies are independent pharmacies. And I'm sorry, I don't know an exact number on how many are owned by a PBM.
Follow-ups, Dr. Halloran.
Thank you, Mr. Chairman. Do you guys make any money on the prescriptions from Medicaid?
Chairman Baldwin
Go
and
ahead.
Representative Hallman, on our prescriptions from Medicaid. I'm sorry, I'm not super good on the hard facts here. But my father, Craig Jones here, who owns the pharmacy, he has lots of those numbers for you. Sorry, I don't have more.
Let's go ahead and pass the mic to him for a moment.
Okay.
Let him introduce yourself and go ahead and tackle that question.
Thank you, Mr. Chairman and Representative Callahan. My name's Craig Jones. I own Basin Pharmacy in Basin. I also am a partner in Grable Drug in Grable. I also own the only cafe, the Copper Corner Cafe in Basin. And my wife and I recently purchased the grocery store that had closed there. So we are invested heavily in the community. And to answer your question, we do make money on Medicaid prescriptions. There are some we lose some. But compared to the other PBMs that we deal with, Wyoming Medicaid reimburses better than the majority of the large PBMs.
Good. I see another hand being raised down here. She didn't get enough of the hot seat yet. She wants to speak. Go ahead.
Chairman Baldwin, Representative Hallinan. I wear multiple hats. I also sit on the Medicaid P&T committee. So Medicaid uses a PBA, not a PBM. And so that's why you actually see that you don't lose money on prescriptions with Medicaid, because they are practicing a different model of business. A PBA would be a much better model in a lot of these scenarios, so that your local pharmacies are not going out of business.
Thank you. Further questions, committee?
Mr. Chairman?
Go ahead, Senator Hutchins.
Thank you. Dr. Carroll, could we get the acronym, the explanation for the acronym PBA?
Chairman Baldwin and Senator Hutchins. So I will love to get you that information. I'm gonna have to look it up again. That was the term I was looking for earlier. But yes, a PBA is a different model that many groups of pharmacies feel would be a better option. I will provide the committee with that information.
Yeah, if you can provide that to LSO and they'll get that out to us, that would be perfect. Further questions, committee? Okay, I know we got at least one more speaker there. He's excited too. No, go ahead, sir. Introduce. Yeah, you're the excited one.
I'm very excited.
Who's excited?
Thank you, Senator or Chairman Baldwin and Senate committee. My name is Matt Meyer, and I am an independent pharmacy owner in Sheridan, Wyoming. I also sit on one of the PSAO's managed care committees, which deals with not networking, but contracting, negotiations and payments made out to about 1,800 independent pharmacies across the nation. So we do have some of those audit numbers that we were asking about earlier today. And really, I guess most of what I had to say has already been covered earlier today with the practices of PBMs and how they are not really helping the industry in terms of managing medication costs. And one of the ways that they are generating profits and revenues is through non-transparency with clawbacks and other forms such as generic equivalent rates, basically reclaiming values in dollars in which they are telling the independent pharmacies that they are making at the point of sale and not being able to make an informed decision at that time to see where they're standing financially. Talking about the pharmacy supply market in terms of the PBM in an audit scenario, returning with an NDC on what is considered a generic equivalent availability in the market to set up their MAC drug lists. Part of that problem is that whether you're negotiating your wholesale supply through a PSAO such as Arete, or you're negotiating it directly with the wholesale company, is the 95% or more requirement that you have to purchase your medications, 95% of your dollar purchases through that primary wholesaler. And inside that wholesaler, there may be 4 or 5 listings of different generic medications. for lisinopril or amlodipine, since that's one of the medications that we've been talking about earlier today. Only one of those generics is going to be your contract rate. So not all generics are priced equally. So if wholesale company, if Cardinal runs out of my contract item, which I'm buying 1,000 tablets at for $13, the next generic equivalent to that may be $800 for that exact same bottle. So we are really hamstrung in terms of the medications, of which medications that we can purchase. And the MAC lists, even though they're updated and adjusted every 7 days, do not take into account market availability. Those lists from the NDCs and based on First Data Bank can be active and currently not available. So just regulating and saying that we have these restrictions on the MAC list in order to ensure that you know we're setting prices based on market availability is not entirely true. And then also procuring medications outside of those primary venues is also a challenge. So I have a real hard time swallowing that PBMs are here in order to decrease costs of medications. If we go back to the chart that was handed out to you during the PBM presentation, the value of PBMs, that PBM's reduced cost has not changed that $1,000 drug cost. That medication still costs $1,000, and anybody in business can tell you that if the drug manufacturer is paying a rebate anywhere along the lines, they have to make that back up somewhere. So even though that the PBM is getting that medication at a reduced cost, it has not changed the drug price for the uninsured patient. It has not changed the drug price to acquire the medication. And in fact, that additional rebate, just based on supply and demand from any business aspect, in order to make that back up, guess what's going to happen later on down the line? That price is going to go up again, and it's further going to contribute to that cycle of rebate being paid, making that revenue back up, increased prices. We have to do the same thing and through negotiations, contract negotiations with the PBMs. It's not really a negotiation process, to be perfectly honest with you. And again, we represent 1,800 pharmacies. We are pretty much handed a contract that says, here are the rates. This is what we are going to reimburse you at AWP minus whatever, plus a dispensing fee, which is generally under $1. And then it's either take it or leave it. Being included in the network does not guarantee access to patients. Express Scripts most recently has shown us that just having the Express Script contract to be able to, even if you are a preferred member, they can further narrow that. We saw that just last April 2020. They walked in and forced one of the major employers in the Sheridan area that issued a letter to their members stating that in order to pertain prescription services, they can go to Albertsons, they can go to Ridley's, they can go to Walmart, or they can use mail order. Even though we have a contract that states that we are a preferred pharmacy in the Express Scripts network, they can further reduce that network. So really a lot of patient steering is happening, and in Wyoming, where there's not a lot of other alternatives, closing independents will result in decreased access care, especially in smaller communities where then you are now relying on mail order in order to get those medications. So I'd also like to talk about DIR fees and DIRs. What? And rebates. Okay, yeah. In terms of DIR fees, one of the things that I printed out from our pharmacy, you guys aren't interested in that, is Number one, when DIR fees were first introduced, we were talking about a 2 to 4% DIR fee. And a DIR is assessed generally 6 months down the road. You do not know where you are going to fall into that category. It's based on performance. Some of those performances are based on patient indicators. Some of them are pharmacy versus pharmacy indicators. But for example, last year, we paid out a total in one of our 2 pharmacies of roughly $50,000. For the entire paid for performance, we were able to reclaim 1,600 of that. So basically from CVS Caremark, 6.2% of the DIR fee was refunded and 93.7 was returned to CVS. And it's somewhere in there, but I want to say out of Cigna and Express and United Health, we were able to reclaim 555 of the 50 of the total 50,000 that went out. And we score rather highly in terms of that. There it is. So ESI and Cigna basically returned 5.7%. The PBM kept 94.3. So when they talk about these paid for performance programs and the ability to reclaim some of these DIR fees, it's extremely misleading. And then once we start talking about clawbacks, it's also important to recognize generic equivalent rates, which basically is a funny thing that they do, where they take a look at the entire PSAO, the entire region, and say, well, we overpaid on generics for said pharmacies, and we are going to reclaim from all of the pharmacies, whether they overpaid us or not. We are going to reclaim that amount of money from the PSAO, from the central pay, in order to meet that generic equivalent ratio. And I think it's also an important question to note or point out, since we were talking about Prime Therapeutics earlier today, being owned by Blue Cross Blue Shield. They just recently contracted out their pharmacy benefits services for the state of Wyoming to Express Scripts. So even though Blue Cross Blue Shield of Wyoming owns Prime Therapeutics is not administering the pharmacy benefits for Blue Cross Blue Shield of Wyoming anymore. They have now outsourced that out to Express Scripts. As I said, I think most of what I was going to talk about has already been covered today, and I would stand for questions.
Thank you. Questions, committee? They're going to reel up the committee members. Go ahead, Dr. Hallinan.
Thank you, Mr. Chairman. I don't know what a DIR is or what it's for. Could you explain that?
Chairman Baldwin and Senator Hallinan, I can attempt to. Originally, DIR fees, direct and indirect remunerations, were originally fees that were imposed by CMS in order to try to reclaim some of the unforwarded on manufacturer rebates that were paid to the PBMs for Medicare Part D in order to reduce premiums for Medicare Part D members. That was the original intent back in 2010 or 2013. What's ended up happening is the PBMs have turned around, and rather than, they found another avenue basically in order to help offset that cost to them to maintain their profitability, and have passed that on to the pharmacy. So one of the indicators that basically there's 4 indicators that we are all rated on, and depending on how your pharmacy performed determines what percent or of ingredient cost is going to be reclaimed back by the PBM to to help offset the premium costs for Medicare Part D members. It's, again, it's important to note that none of that, there is absolutely nothing of what that fee is actually going to be at the point of sale. So the pharmacy may believe that they are making a $30 product, but if you're paying a 10% DIR fee 6 months down the road on an ingredient cost of that $300, that's $30 going back. Now you're at zero. And in a lot of cases with the contracts that are being forced upon us in order to participate in these networks, particularly on brand name items, we're not seeing 10% profitability on those items. We're seeing a few dollars, and now you're taking that additional 10% back. You're looking at, you're quickly in the hole. And again, it's 6 months down the road. It doesn't make a lot of sense.
That's a good way to end up. Representative Flitter, go ahead, ma'am.
Thank you, Mr. Chairman. And Dr. Jones or Dr. Hancock, maybe if you could answer this. So if the pharmacy benefit managers were to go away and you were left to the free market system as a small independent pharmacist, do you feel like you would be able to then provide that drug to me at a better cost? Would you be able to do that?
Thank you, Representative Flittner. Yes. Yes. PBMs, to boil it down, are a parasite on the healthcare system. They're like a tick on a horse. They're sucking the blood with providing resources that are already there. My wholesaler is already getting the best price they can from the manufacturers. Pharmacists are already monitoring drug interactions. They're already providing care to a level that the PBMs cannot even begin. Pharmacists are there physically, independent, talking to the patients, seeing the over-the-counter items they're taking. And we're funneling billions of dollars into PBMs, into these parasites that are a duplicate to our healthcare services that are already provided. And it's, overall prices would go down. Thank you.
Further questions, committee? Representative Conley.
Yeah, thank you, Mr. Chairman. I would assume that you are among the 20 Wyoming independent pharmacists that requested of us that we take a look at this issue. And it was a very specific request that we create legislation that mimics the Arkansas Act 900. But I'm curious about model legislation that was also suggested in the LSO brief and also the Texas statute that just passed. And so I am curious about your thoughts among those options. If we weren't to, for example, just get rid of the tick, as you called it, but instead to go another route, which is modification.
Go ahead.
Thank you. So Representative Conley, I initially was really pushing for the Arkansas Act 900 because of the U.S. Supreme Court ruling back last year on my birthday. It was a good day. But I saw that and I was very excited to see that something had been so succinctly said and backed up by the highest court. And in an effort to move quickly and try and get something rolling, I was suggesting that policy to be put in place because I knew how desperate of a situation our pharmacies are in. And I'm obviously very young, very naive, and I was did not know how to craft my own legislation. And I've been learning a lot along the way. And so that's why we initially suggested and pushed to have that that topic placed onto the interim hearing this year.
Mr. Chairman, just to follow up, but again, Arkansas versus Texas versus model legislation, do you not have preferences? You just knew about Arkansas and liked it and it was passed on your birthday, so, okay.
Thank you, Representative Conley. Obviously Texas had not been placed back in December or January when I started getting this ball rolling. I do really like what Texas has done. If we were to be perfectly honest, I would love to squish the tick. But if our options were to try and follow legislation that's already been passed, I would prefer the Texas legislation.
Further questions, committee? No further questions. Oh, further answers, presenters. Go ahead.
So I wanted, sorry, Chairman Baldwin, I would like to address a question that Senator Bouchard had previously about, or actually it might have been Representative Worf, about the piece in the Texas legislation that raised concerns with my colleague, and that's the specialty pharmacy, them not being able to do inspections and, you know, further accreditation for these pharmacies. So there's a term that's called white bagging, all of these acronyms and terms. So what white bagging is actually a way for PBMs to get involved in the hospital side of billing. So saying that they're not involved in hospital pharmacy isn't entirely true. So specialty drugs, as my colleague stated, do have a lot of parameters around them, a lot of, you know, considerations to be made. And we are all trained in handling many, many drugs. And I would argue that hospital pharmacists are very good at handling chemotherapies and those kind of very hazardous, very specialty drugs. What this is requiring these pharmacies to do is to use the PBM specialty pharmacy to prepare said drug at that specialty pharmacy and have it shipped into the hospital, where then that hospital pharmacist has to use the specialty drug from the PBM and not the medication that's at the hospital. That raises some concerns with stability, things like that. It also is, again, a way that PBMs are injecting themselves into the hospital system. So are they concerned about that? Probably, because it's another avenue that they are injecting themselves into the healthcare system. Again, requiring those hospitals to use the specialty pharmacy that the PBM owns.
Thank you very much for that. Okay. Go ahead, sir. I was just coming to you. I still got the image of the tick in my head.
Oh.
Go ahead.
All right. Thank you. I just want to kind of sum things up on some things we've talked about. And this is the most confusing thing. I think one of the Supreme Court justices called it a Byzantine mess, meaning it was so complicated that it was impossible to understand. And I appreciate everybody's patience. But I think what it boils down to is whether we want to have independent pharmacies in our communities or not. This morning, I ran a report showing the medications that I had been reimbursed less than my cost. This is since the first of the year. This is my list. Each page has 15 prescriptions, total of 2,000. Let me get the last page here. 2,062 prescriptions I've been reimbursed below my cost. Now, some of these are generics. I do receive a bit of a rebate on the generics. But like on brands, that is the cost, my cost. Just an example, we heard from Prime Therapeutics here a couple of weeks ago. I dispensed some insulin to a patient. My cost was was $420.06. Patient's copay was $60. The insurance paid $249, making a net loss of $110.53 for me. I get no rebate on that. I just paid Prime Therapeutics $110 for the pleasure of dispensing a medication. Is that fair? Is that what we want? Can I stay in business like that? I can't. And unless some of these things change, I'll be gone. And with it, probably the other businesses I own. And we're left with a county seat that is a shell of a town. And it's going to happen throughout all the states. Last year, I didn't make a profit. Part of it was because of COVID. But I think if you'll check, Prime Therapeutics didn't make a profit. They're separate enough from Blue Cross Blue Shield of Wyoming. I think like 4.73 billion was their profit last year. If you want to check that. Other PBMs are in the same business. If they're making that kind of profit, is that really lowering our healthcare cost? The money that they save is actually taken from the pockets of our communities, of our local businesses. And we need to do something. Thank you so much for your time.
Thank you very much. And we appreciate you bringing the conversation to the table. It's certainly needed. And go ahead.
Sorry, I just want to point out, I do have some colleagues who are on Zoom and they're very anxious to testify as well. So
Yep.
thank you.
They're coming up here soon. And this is a point in the committee meeting where we've heard most everything at this point. It's been shared one way or the other on both sides. Some of those who are going to present will have some of the same things to say. I would suggest that rather than reiterate everything that's already been said, add some things new. And but again, we appreciate this being brought to the table and this being discussed. It certainly needs discussed and it's not done. There's a lot to go yet, but thank you very much. Are there any others in the room who wish to speak to the committee? Again, there's no arm waving and jumping up. Okay, very good. Let's switch to our online folks.
Mr. Chairman, I'll let them all in at this time. I believe there are 4 of them, and the first is Amy and Scott Schmidt.
No. Are you able to hear us?
We can hear you. We can't see. We can see your
Okay.
name, but
All right, here we
there
are.
you are. We can see. Introduce yourselves and I'd wave back. It seems like I should, but go
Well-
ahead and introduce yourselves and speak. Go ahead.
Okay, my name is Amy Schmidt and my husband is Scott Schmidt. I'll let him introduce himself as well in just a second. We own North Star Pharmacy and Infusion in Cheyenne, Wyoming. I'm not a pharmacist. I actually have a master's degree in social work. And so what I want to share with you today is a little bit more of the human connection with things. Obviously, I'm a little emotional from that last testimony because I see how hard these pharmacists work. And it breaks my heart to see them lose money like this when they're the ones trying to help their community. So obviously you can tell I'm the social worker because I really have that human connection. So the story I want to share with you, when you talk about accessibility to medications and what's important around that, I want to share a brief story with you regarding a patient that we have in our pharmacy, at least that we did have in our pharmacy. This patient, while we had her, her husband passed away. She lived in a bi-story home and she was unable to get up and down the stairs. And our delivery driver asked us one day, what happened to this particular patient? And we told him she was moved to mail order. She had to do a mail order pharmacy. And he said, he got tears in his eyes because he said, I would go to that patient's house to deliver her medications, and that patient could not go up and down the stairs. I took her mail to her. I fixed her furnace. I delivered her medications up the stairs to her because she was not able to get down those stairs. Now she's switched to mail order pharmacy. If she wasn't able to get to her mailbox to get her mail, she doesn't have accessibility to drugs. And when we start forcing patients to go to certain pharmacies, or we start forcing patients to use mail order, we're breaking down the healthcare system, and we're not allowing those patients to get the services they need. It is in our communities that these things are happening, that we're taking care of the people in our communities. And listening to the story, I mean, buying a grocery store because you know that your community is going to be without one. The heart of these people in their communities is why things are successful and why people's healthcare is changing. It's not a random letter in the mail telling them, hey, I noticed you didn't get your blood pressure medication. There's so much more to it than that. And I just want to share that human aspect of every person that works in our pharmacy has a concern for our patients. And knowing that a patient's accessibility to drugs was hampered just by putting them on mail order, I think is important to be addressed. And so I just wanted to share that personal human story of an actual situation. So I'll let Scott take over from now.
It's a good thing I have the sensitive side. So it was mentioned in that PBM discussion earlier from the lady that spoke from Prime Therapeutics. On one of her slides, it talked about House Bill 63. Now, the previous administration allowed pharmacists to explain these kind of practices that have been going on behind the scenes to their patients. So for many years, and I'm sure many of you have never known or heard about these very same things because we can't talk about it. If we talked about it, we'd lose our contracts with the providers. We'd lose our contracts with Blue Cross Blue Shield. We would lose our contracts with Medicaid, and so on and so forth. And so we weren't able to discuss how bad we were getting kicked in the mouth. And so to everyone's question earlier, I mean, it's a good thing I'm probably via Zoom and I was off camera because I was probably dancing around in my office every time the lady was speaking from Prime Therapeutics. But in answers to most of the committee's questions, during the pandemic, the manufacturers for insulin, for those that were not insured, lowered the cost to insulin to $35 to those that didn't have insurance. Now, just simple math. I mean, you heard Mr. Meyer talk about him paying $428 a vial, and the patient's still paying $60 for the copay. So right there is proof that if we get rid of PBMs, healthcare costs go down. Second of all, in what we do down here in Cheyenne, we have an infusion company and we have a retail pharmacy. So we are accredited with the National Association of Boards of Pharmacy. And Prime Therapeutics still requires all their patients that are on specialty drugs to use a Credo pharmacy from back east somewhere. And so what they do with a Credo is a Credo then contracts with whatever manufacturer of Humira, Enbrel, Clopaxone, any of the chemotherapy drugs that Melinda was discussing earlier at a fraction of the cost. So just like we were talking about the Hep C drug, my cost, as a matter of fact, I've had a couple patients with Hep C. I paid the full $100,000 for the drug for the 12-week course. To give you an idea, when Prime Therapeutics put that slide up, so my cost for the drug was $1,000 a pill. In a 3-month period for those 12 weeks to go through, my overall profit on a $100,000 drug was $750. And I have to fight the PBMs and fight Blue Cross Blue Shield anywhere from 21 to 45 days worth of cash flow to hopefully get paid on that. And like Camilla was saying, if we didn't sign or print just right, or if the doctor didn't do the proper diagnosis and actually mapped out which enzyme was correct so that they could get the right Hep C drug to make sure that it was cured the first time, because sometimes they had to go a second term, they could come back and take that reimbursement from me and the patient still got the drug. So my profit, just to give you an idea, Prime Therapeutics got 41% profit margin. Me dispensing the drug, I got 0.89% profit margin. So they net profited $34,524 and I got $750. And so I called an appeal, and I told the lady on the other end of the phone, I said, it'd actually be cheaper for me to let the patient die and pay for its funeral than for me to dispense this medication. We don't want that kind of healthcare. We've given over 6,200 COVID shots.
In our pharmacy.
In our pharmacy. 700 of them, I've personally gone into patients' homes because they couldn't get out. They were bedridden. I work 90 hours a week, run a $10 million business on a 3% margin. That was slashed in half last year. Now call me crazy, but there's not many businesses or many other professions in the world that run a $10 million business for $150,000 or $300,000. And not to mention, I'm employing 23 families, paying their health insurance, matching their 401ks on a 3% margin. So I implore you to listen to us Wyomingites that are proud to be in Wyoming.
Mr. Chairman.
Go ahead.
Thank you. And if I could just ask Dr. Schmidt online and also the doctors at the table, show of hands, how many of you have been through the appeal process? One, Dr. Meyer, Dr. Jones, Dr. Schmidt, you all have?
I have.
So, okay. So if I could just get maybe one of you to speak to that briefly and tell us how successful that's been for you.
If I could step in, I've gone through the appeal process. It took me over 6 months to figure out what Prime Therapeutics was actually doing. So now that you all kind of understand PBMs and sorry, let me start my video. Now that you all understand PBM, sorry, my name is Chadwick Pharmacist. I'm a PharmD. I started my own pharmacy 16 months ago, right in the middle of the pandemic. I vaccinated 40% of my community so far. I stand for community pharmacy. As it was mentioned back in April of 2020, Prime Therapeutics made a big change. You know what Prime Therapeutics did that Dr. Harper forgot to mention? They teamed up with Express Scripts. So there's actually 2 PBMs. PBM is crooked and it's a tick. Well, Blue Cross Blue Shield has 2 ticks on its back. It has Prime Therapeutics and it has Express Scripts. This does go to your MAC appeals question. I fought Prime Therapeutics for months on MAC appeals, getting denials, getting different stuff, having different people fight it for me. My PSAO that I pay $189 a month, fighting MAC appeals for me. After 8 to 9 months, I got an email from Express Scripts that said your contract is in place for 2 years, or you signed a 3-year contract. Once your contract is over, we can look into new stuff. And I said, what does this have to do with? And it says all the MAC appeals you've been putting in place. So I fought MAC appeals to my finest through every avenue I could for 8 months before I found out Prime Therapeutics was messing me around so bad because they switched to Express Scripts. It truly goes through my Express Scripts contract. If I were to get a MAC appeal on a Prime Therapeutics claim, it is truly through Express Scripts. So now that you guys have grasped how bad PBMs are, how can Blue Cross Blue Shield have 2 ticks on their back? We can't do it. I could go through the claims. I have a list of claims like they do. Here's a drug I paid $1,500 for. I have to wait 30 to 60 days to get paid, and I lose $44 on it. I fight MAC appeals back and forth. And when you finally get there and you finally get to Express Scripts, you know what Express Scripts says? Paid at contracted price, recontract with us in 3 years. So, you know, the MAC process, that is the MAC process. In the MAC process, the percent of approvals to denials that one person asked is limited to null. And I'm sorry, I jumped right in. I should have first said, you know, thank you very much, all you senators, all you representatives. I'm very passionate about it. I'm here. You've heard a lot. I don't want to go over a bunch of it. But that's to speak to the MAC process. That's how the MAC process goes.
Thank you. We appreciate your enthusiasm and passion. I believe we have one more.
Mr. Chairman and Representative Flitner, just to answer that, out of 825,737 MAC appeals, only 1.8% were actually had the price adjusted. And that's not had the price adjusted to the pharmacy for a profit. That's just had the price adjusted. 1.8% out of 825,737 for our PSAO.
And I believe we have one more response. Go ahead, sir.
Yes, Representative Flitner, I literally, any claim I'm reimbursed under $3 for, or over, if I'm less than $3 or more, then I appeal through my PSAO. And I literally have a banker box. The pile would be this thick of claims. I don't know, maybe 5 out of how many thousands are in there. Medicare, or excuse me, Medicaid's a little better. I probably have had half of my appeals changed with them. Have to fill out some forms and send in. But for the regular PBMs, I do it just to document it so I can show that they don't.
Very good. And I believe Scott wanted to say something there online. Is that correct? Go ahead, sir.
Thanks, Mr. Chairman, and committee, I appreciate the opportunity to speak. I fight the PBMs all the time, and part of the reason why you lose so many is you just get so bogged down because you're doing everything else behind the bench and trying to run the business that there's not enough hours in the day to call and talk to some of these people that make it just so dang difficult to get through to anybody. And so when they talk about their transparency, or a lot of the reason why pharmacists just really haven't talked is because we're actually afraid that by being here discussing this today, I bet next week I'll have an audit from Prime Therapeutics that's going to fine me for whatever scripts they're going to go find for the last 4 years, and then they're going to take money back from me to pay for their lobbyists, and then to further put us down under. And so they're not a transparent party of the healthcare system. And I think with COVID this last year, I think we saw how fragile our healthcare system was. It was sad to see, but us community pharmacies, we stayed open. We were there. We were in the trenches. We didn't go telehealth, telemedicine, where a lot of the doctors did. A lot of doctors are like, I don't want to see patients in my office because they're sick. I had a mask on. We got vaccinated. We did what we had to do to make sure everything was taken care of, so our patients had the medications that they needed. And just in a reference of the mail orders and things like that, those drive costs up about 100,000%. Just think for a minute, if a drug, if somebody that's on rheumatoid arthritis or psoriasis, those kind of things, Enbrel, Copaxone, those are $6,000-7,000 a month. And when these PBMs want to send them through the mail, and today in Cheyenne, it's 92 degrees outside. If that doesn't hit the patient's house just right,
Well, and
we're out to $7,000.
We've had patients whose specialty medications have sat on their porch and spoiled and ruined. And, if you're going to spend $100,000 on a medication, I would think by all means you want a person giving that person that medication. You don't want the mailman doing it and hoping that they get it before it's too hot or too cold or whatever the case may be. And so, there's a lot of these issues where healthcare requires people. And, we've become a society through COVID that everything's done virtually. And you know what? When things start cleaning up and we start getting healthier again, we need to get back to the people. And that's one thing we love about Wyoming is it's about the people. And we spend our time doing things for the people. And that's what we need to remember. Somebody's healthcare is not solved over a Zoom call or a telephone. It's taken care of by interacting with each other face to face and having those interactions.
Thank you very much. Committee members, further questions? Representative, go ahead.
Thank you, Mr. Chairman. Mr. Meyer, I was just wondering, with the amount of claims that aren't, or appeals that aren't paid, I guess, is it that the claims are denied, or are they not settled, or are they not handled? Is coding a problem? Thank you.
Chairman Baldwin and Representative Ottoman. No, those claims have been paid. Those were not denied claims. Those were claims that were submitted, and due to the MAC or contractual rate at AWP minus X amount plus your dispensing fee, ended up costing less than my generic contract cost through the wholesaler. If that answers that.
Further questions, committee? Seeing none, you might really be off the hook this time. Do we have some more online presenters?
Mr. Chairman, next we have Caitlin.
Thank you very much, Amy and Scott. That was a very good presentation. We appreciate you coming in today. Caitlin, we're anxiously awaiting you.
Hello there. I'm trying to turn on my video so that I can see you all, and so you can see me rather than this lovely picture that we have up there. There we go. Hello, everyone. I'm sorry, can you see me and hear me okay?
We can see you perfect. Go ahead and introduce yourself and go ahead and speak.
Thank you, Mr. Chairman. Thank you, members of the committee. My name is Caitlin Lucarello, and I'm the Director of State Policy here in the Rocky Mountain region for the Pharmaceutical Research and Manufacturers of America, or PhRMA. Thank you for letting me weigh in on this discussion today. And let me just start by saying I feel a sense of gravity in this discussion today, and just want to recognize those folks that have met this topic with facts and empathy this afternoon. PhRMA, for my part, PhRMA represents 34 of the country's leading biopharmaceutical manufacturers. And we believe that discussions like this one that you're having today are extremely important. They're especially important. However, right now, we've heard from many today and know of so many folks that are facing financial struggles following the COVID pandemic, and pharmacies, providers, and states, which are all facing additional financial pressure. I'm going to focus today just on our industry interactions with PBMs, but I do hope that we can be part of this continued dialogue on pharmacy costs. The COVID vaccine innovation that we've seen, bringing 3 safe, highly effective vaccines to market, is just a small piece of really a new era of medicine that we're in, where manufacturers are creating very innovative, personalized therapies like cell and gene therapies that address not just the symptoms of the disease, but also the cause of the disease. Some of them are curative, and many are transforming the lives of patients and offsetting costs that would exist in the healthcare system. Over the past couple of decades, our 34 members alone have invested about $1 trillion in research and development of those new medicines, and have reinvested around 20% of their profits to do so. I think we've all become very aware, maybe some of us too aware today, that a medicine's path from the biopharmaceutical manufacturer to the patient is very complex. It involves many entities, and manufacturers do set, as was said before, the list price of a medicine. But Our list price, while it has an impact on what patients pay, as you've also heard today, there's a number of entities that really play a role in the price that a patient pays when they go to pick up their medicine at the pharmacy. And to illustrate this, nearly half of all spending today, every dollar, so 50 cents, let's say, of every dollar spent on medicines is going to other areas of the supply chain, like PBMs, insurers, and wholesalers, not to the manufacturers that are manufacturing, researching, developing those medicines. You have also heard today a lot of leverage of PBMs in the system. We've heard that 3 PBMs control around 75% to 77% of pharmacy claims. The top 5 actually handle about 95% of pharmacy claims in the US. It is a huge market share, larger than any single drug manufacturer has here in the United States. And PBMs don't just work for payers. They're often one and the same. So we heard PBMs say today, payers don't have to use us, but often in the commercial market, they are also the payer. 5 of the 6 largest PBMs are part of these large vertically integrated organizations that combine insurers, PBMs, specialty pharmacies, mail order pharmacies, et cetera. And let me just also be clear that manufacturers do not own any pharmacy benefits managers. They are basically highly profitable intermediaries, middlemen in the system that don't actually put their hands on the drug. They bear very little risk. And, I would encourage you to go home tonight and look at the Fortune 500 list of the most profitable companies in 2020. It will take you till number 36, 37 on the list to get to a manufacturer that actually does the research, development, and manufacturing of a drug. But in the top 10, you'll see many PBMs. As you've heard from both the PBMs and pharmacies, PBMs use their market power to leverage rebates and discounts from manufacturers. And if a manufacturer can't negotiate, and this is the truth, a drug just may not be covered at all. At the start of 2021, 200 medicines were dropped off of formulary by the top 2 PBMs. So this happens all the time. And because of the market share that they hold, these exclusions have really widespread consequences for patients. I also just want to speak to the rebate amounts which are being paid, and we're growing increasingly concerned that manufacturers are paying significantly larger and larger amounts of rebates, and at the same time, patients' out-of-pocket costs are not decreasing. In fact, they're going up. Manufacturers paid around $166 billion in rebates in 2018 to PBMs and other members of the supply chain, and $187 billion in 2020. What this really amounts to is around a discount of 40% on average for brand name drugs. And we know that for other classes like insulin, which has been talked about today, last year negotiations in the supply chain lowered the list price of insulin by 83%. That is what those payers, that's the price that PBMs and health plans are paying, 83% off of the list price. We have heard about skyrocketing drug costs today, and what we do see is that actually these negotiations are keeping net prices very stable to decreasing. Average net prices declined for brand name drugs by 2.9% actually in 2020. But again, it is a system that is working well for some. As we've heard time and again, patients are not benefiting from these negotiations. And in fact, kind of the opposite is happening. They're being required to take on a larger share of the costs. And often that is based on that list price of a medicine. It's not based off of the discount that the PBM or the manufacturer is receiving. So as we've heard today, a patient can be paying more than the PBM or the plan. And I will in the interest of time and knowing it's late on Friday, let everyone know that I will close very shortly here, but also wanted to just talk briefly about PBMs and insurers increasingly also implementing accumulator adjustment programs, which is to say that the cost sharing assistance that manufacturers are providing to help patients meet their out-of-pocket requirements no longer count toward a patient's cost sharing. And what that really does is it means that the PBM can collect both the copay assistance from the manufacturer and then the full deductible paid by the patient. So ultimately, PBMs and insurers are benefiting from these manufacturer copay coupons at the patient's expense. I think we have heard certainly a lot of problems today. Pharma believes that there are many workable solutions that are market-based, that are pragmatic, and will help end some of these perverse incentives that we see in the system. Many you're discussing today certainly believe that shining light on some of these opaque PBM practices will help us get a better understanding of the system, and that's a good start. We also think that we should ensure that the rebates that manufacturers are paying to help sick people afford their medicines actually go to do that, and that patients can benefit from copay assistance provided by manufacturers like they traditionally have. Again, thank you so much for letting me provide input on the conversation today, and hope that we can be part of the conversation about this and other topics as it relates to prescription drugs in the future. Hope this is just the start, and very happy to take questions.
Thank you very much, Caitlin. Questions, committee? Go ahead, Senator Bashard.
Thank you, Mr. Chairman. Caitlin, I saw where you, various quotes I've just to narrow down, where you say that the medicines list price, not the net price after negotiated rebates and discounts, are the kind of where the problem is. Your quote is, "We need to make sure that the patients benefit from these discounts when they pick up their prescriptions at the pharmacy counter." So my question is, do you think the Texas legislation does that? I mean, I've looked for answers online. I can't find them. So I want to know what your opinion is of the Texas legislation. Thank you.
Go ahead, Caitlin.
Thank you, Mr. Chairman. Thank you, Senator, for your question. As it relates to rebate pass-through, which is what that policy is called by patient groups and pharmaceutical manufacturers, the Texas legislation does not contain a requirement to pass rebates through onto consumers. There is one state that passed that legislation this session. It is West Virginia. On Texas, as an industry and as a trade organization on that PBM legislation, we were neutral as an industry. However, as I said, we do think that meaningful transparency across the supply chain and shining light onto some of these opaque PBM practices, additional PBM regulation is a good start.
Follow up. Go ahead, Senator Bashard.
Thank you, Mr. Chairman. Now, there are some good things in Texas, so I want to know if we could maybe take some of that and some of the legislation that you mentioned. So there's disclosures and things that are in Texas. If we combine those with the legislation that you mentioned, I mean, I'd like to do something where we're doing something maybe and not just copy another state, but actually bring something and develop something even better. So, and also, any other ideas you could bring forward that we could do something like that?
Yeah.
Go ahead, Caitlin.
Thank you, Mr. Chair. Thank you, Senator, for your question. So absolutely, I think you could certainly combine policies if you wanted to take some of the best practices from other states and combine into one bill. As I said, West Virginia is the first state to require rebates be passed through by PBMs to patients at the point of sale. But there are also private examples of this. A number of health plans are actually starting to pass through rebates voluntarily. And so it is a practice that is already starting to creep up in the private market. As I mentioned earlier, we're also very concerned about accumulator adjustment programs and the fact that patients, which were once able to use these copay cards and coupons and it applied toward their cost sharing, are no longer able to do that and are being faced with kind of this surprise when they go to pick up a drug at the pharmacy and they realize that they have been using manufacturer assistance and it hasn't been chipping away at their deductible. There are 10 states that have passed accumulator adjustment program bans, and be more than happy to talk to you in the interim about all of those policy ideas.
Thank you very much. Further questions, committee? Go ahead, Representative Romero Martinez.
Thank you, Mr. Chairman. My question is based on a bit of research I just pulled up, and we've been going through a lot of information, but looking at the DIR fees, it says here, upon doing some research, that there's a loophole in Medicare and Medicaid, and that what it's saying is prescriptions payers are taking back money paid to by pharmacies. Is that pretty much the same thing that you're talking about with these accumulator adjustment programs that seem to be causing some problems?
No, sir, it is, excuse me, I'm sorry, Mr. Chairman and Representative. No, they are not the same. And actually, I would defer to the pharmacist because DIR fees are a bit complicated and aren't really an area that I'm familiar with. The accumulator adjustment programs are programs that are being increasingly implemented by PBMs and insurers, which say that the copay cards and coupons that manufacturers provide to basically help patients chip away at their cost sharing no longer count toward their cost sharing. So what this looks like is somebody has come into the pharmacy several times over the course of a year with a copay coupon. Let's say it's $100 and their deductible is $1,000. Those copay coupons don't last forever. So maybe they last for 8 months. They come in and they use that copay coupon for 8 months and they think that it's applying toward their deductible. But the reality is it's not. And they are left with, after those copay coupons expire, their full $1,000 deductible that they have to pay. And so that is a different issue. It's a manufacturer issue, not a DIR fee issue, which tends to be an issue that's more pharmacy related. And again, would defer to the pharmacies on that issue specifically.
Thank you. Further questions, committee? Seeing no hands. Thank you very much for your presentation and answers to questions, Caitlin. We appreciate you coming in today.
Thanks for having me.
Mr. Chairman, next we have Chadwick.
All right, Mr. Chairman, Madam, Senators, Representatives, I thank you all for giving us the time and listening to us. We've made great success today for you guys to even understand PBMs and understand how crooked they are. DIR fees are a lot rougher. We'll get into those later. Just helping us with this has been amazing. I'm not going to beat it up. It sounds like you guys understand PBMs. Senator Hutchins made the comment, we live in a capitalistic world. If you make something, you're going to sell it for what you're going to sell it for. At the same point, Representative Romero Martinez said, well, if there's this $1,000 gap in your PBM, you're getting $400. Where's that $400? Prime Therapeutics didn't give anybody a real answer on that. It goes to Prime Therapeutics. They do make money on it. So the biggest deal is realizing pharmacy. I remember 5 years ago, the balloon we're talking about, we were only 6% of that balloon. The total healthcare cost in America, we used to only be 6% of. I bet we're lower than that now with everything that's going on. So that being said, if we're 6% of the balloon, PBMs are 40% of the balloon. What do PBMs do? That's your question. What do PBMs do? They get paid those deductibles. Do they vaccinate 40% of their 4,500 person community like I've done? Do they do med reconciliation on people? Do they give free blood pressure meetings to people that come in? Do they save people hospital visits that come in with weird rashes, fevers, stuff like that? No, PBMs don't do anything like that. They're not feeding into healthcare at all. They are draining healthcare. So just to answer what they do, I did want to point that out there to understand they don't really do anything. We'll quit beating them to a point, they're sucking it. So I have so many notes and I had so much, I don't want to go over a bunch. I live here, I've been here, I'm working 90 hours a week like Scott. I opened this up 16 months ago. I'm here 6 days a week. I haven't done much legislation. I haven't got out of here. Luckily, Amy Schmidt has done more for the state of Wyoming than anything. Camilla coming up and doing what she's doing, putting this together with her father is amazing. However, that's a handful of people we have in this right now. We have all these independent pharmacies across Wyoming, let alone across the nation. If there's not something done, we will shut down. Scott paid over $150,000 or about $150,000 in DIR fees last year. I've paid close to $20,000 so far. And what they are is different than what Caitlin was talking about. DIR fees are med that they take money whenever they want. I'm expecting a $10,000 check from Caremark because it's been about 14 days and they're supposed to pay in 14 days. I only get a $5,000 check and the rest of it's DIR fees. So that's how DIR fees come. They don't tell us anything. We don't know when they're coming. You don't get as much money as you thought. So cash flow in pharmacy, there's not such thing as cash flow, and mainly because of the DIR fees. If you don't know what you're going to get hit with and when, you can't put a cash flow together. Other than that, I just want to thank you all for listening and please keep working on this. If there's anything we can do to help you understand it, yes, just thank you all very much. I'm open to any questions from anybody.
Very good. Questions, committee? I have a question. It has nothing to do with the topic. It has to do with your enthusiasm and passion. And I'm a tie guy. I want to know what it says under 2 apples a day. I see that on your tie. What else does it say?
What's that now? Oh, my
Your tie says 2 apples a day.
Yeah, I got RX at the top. I got avoid sunlight with taking this, take with food. My mother got me this tie when I was in pharmacy school and I wear it today. And you can see I'm proudly wearing it with my Wyoming cowboy clip because that's what we're representing. So yeah, no, I moved to Buffalo to work in a small independent pharmacy so I could take care of people, hunt and fish. Well, guess what? I'm in Buffalo. I opened my own pharmacy 16 months ago. I haven't had much time to hunt or fish. I'm working harder than I've ever worked in my life. I'm making less money than I've ever made in my life, but I'm taking care of patients and I'm trying to advance the practice of pharmacy. And if you guys help us, well, then I am advancing the practice of pharmacy.
Thank you very much. We appreciate your passion. I appreciate your tie. Katie, do we have anyone else out there?
Mr. Chairman, Lindsay is next.
Lindsay.
Okay, I am Lindsay Davis. I started a pharmacy here in Wheatland, Wyoming 2 years ago. I agree and have heard a lot of what has happened today and I've heard that over and over again. The stories are true. Our passion is there. Serving the patients that come in every day, worked harder than I ever have in my life to be here, put in the hours. We had people that were forced at Banner Healthcare to go mail order. I've had to rescue them because their mail order hasn't come. And that's supposed to be a healthcare hospital that would appreciate people and realize that your medicine that you need sometimes has to be there physically. I come in on the weekends. I do nursing home charts and consult for the nursing home here. I had a $4,000 audit from Humana that I'm still appealing back from November that I haven't heard anything back from the company on. I usually get people a better deal on their generic drugs than their insurance company will charge them. Sometimes they'll be $40 for a prescription that really should be $15 or $20. Just glad that we're discussing the PBMs and their negative reimbursements and their DIR fees so that we can provide better care to our patients. And I think that our passion is there to get medicine to the patients, and we're the best ones out there that can do that. Thank you all for your time today.
Thank you very much, Lindsay. Are there any questions for Lindsay, committee? Seeing none, I compliment you on the colors in your pharmacy. We like the brown and gold.
Thanks.
Thank you again for coming in.
Thank you.
We
Have a great
appreciate you
day.
taking time. You too. Thank you. Further presenters, Katie?
Mr. Chairman, Dr. Schmidt and Amy have a further comment.
Okay.
Mr. Chairman and committee, again, I just want to throw out the fact that, we're here on the front lines for a reason. We take pride in what we do. I invite any one of you guys to come down to my pharmacy. I'd love you to see it. It's open door. I'm transparent as all get out. I'll show you the books. I'll show you the numbers. I'll show you what we buy drugs at. And I'll show you the real deal. And I pride ourselves in being part of the healthcare profession that's the most trusted. And it's because we tell the truth, and we love our patients. And more importantly, with Representative Richard, I appreciate the fact that we're willing to get things done and maybe put a couple things together. Most importantly, though, I want to make sure that we're protecting independent and community pharmacy, that we are able to function in somewhat of a profit. I mean, I'm not saying we're going to be lucrative rich and all that kind of stuff, because that's not what it's about. Most of us will give the shirt off our back for a patient that walks in the door that needs something, just as Lindsay demonstrated just now. So that's not it at all. But we want to have a fair, competitive market. And I know CVS and Target right now, down the street, if they dispense a azithromycin, a Z-Pack to a patient, and I dispense the same Z-Pack, they're getting paid $400 and I'm getting paid 8 cents. So it's mind numbing.
Well, and
the amount of discrepancies that there are when those PBMs and those pharmacies. CVS was smart. CVS bought Caremark. So it wasn't Caremark buying CVS. CVS bought Caremark. So now they can price fix. They can avoid all the DR fees, all the negative reimbursements. They don't have to do the MTMs. They don't have to do anything that we're held accountable to do. So if their patients are non-compliant, it doesn't matter. They can dispense the same antibiotic that I do and make $3,000 profit, where I make $10 if I'm lucky.
And I think the thing to point out too is, I mean, we're playing a game that the rules changed. And there, I mean, if we had a level playing field and we could play a fair game, by all means, are we ready to play that game? Because we want to give to our patients. Each one of you that have spoke today have showed you how much you sacrifice for your patients. But we can't play a game that's not fair. And like Scott said, you're welcome to come to our pharmacy, but you're welcome to come to any of these independent pharmacies across the state. You let us know where you're at. We'll find what pharmacy is closest to you, and you can go in and see what we're doing and the difference we make. I also work with independent pharmacies across the country. I oversee 9 different states in our region, and I know how hard these pharmacies work. I never thought I would know this much about pharmacy, having a social work degree, but I love these pharmacists. I love what they do for patients. I love how they try to help them. And I will do everything in my power to help them stay successful.
Okay. Just trade.
Thank you very much. Any further comments? No more online, Katie? I got a hand at the end of the table. Senator Hutchins, you have a question.
Thank you, Mr. Chairman. This question is for Amy and Scott. Can you give me the name of your pharmacy or just what street it's on? I'm also located in Cheyenne.
You're in our district, so we know.
We're North Star Pharmacy and Infusion, and we're located at 7121 Commons Drive. So if you know where the Maverick gas station is on Yellowstone, Gardenia, you are just right about at our pharmacy.
Oh, sweet. Thank you.
Yes.
Representative Stivar.
I'm also Cheyenne, and you guys did my daughter's MS infusions. Great job.
Thank you for allowing us.
Okay, any further commenters, Katie, online? We hit them all. Any other public comment in the room? I see one. Come on up. We'll make. I accept it. We need to, the people online need to hear you, so you need to be on a mic. They can't hear you in Evanston from back there.
Thank you, Mr. Chairman. My name is John Kinder. I work for Smartfield Management Group out of Austin, Minnesota. We are a retail buying group. One of the questions that came up, I believe, from Representative Wilson, there are currently, as of 2020, 16 traditional chain pharmacies in the state, 22 supermarket pharmacies in the state, 18 mass merchants, and 45 independents. Thank you.
Any questions?
Nope.
Chairman Wilson, go ahead.
Thank you, Mr. Kinder. So I was writing rather rapidly. So of those, so I have 16 chain, 22 supermarkets, 18 mass something.
Mass merchants,
What would that be like?
Walmart,
Okay. And so then,
and then
Mr. Chairman.
45 independents.
Mr. Kinder, then, so of all of those, the chain, the supermarket and the mass merchants, how many of those are owned or own a PBM?
None of those except the CVS, which would be located in the Targets, which would be CVS Caremark.
Okay, thank you.
One of your other questions were if PBMs own pharmacies in Wyoming. Currently 2, Omnicare, which is owned by CVS, but that's a long-term care solution, non-retail. And then Genoa Healthcare, which is traditionally psych, and that is owned by OptumRx.
Thank you.
Further questions, committee? No further questions. Oh, Representative Flitner, go ahead.
Thank you, Mr. Chairman, and Mr. Kinder, thank you for being here. You said you're a wholesale distributor out of Minnesota, is that correct?
Actually, I live in Casper, Wyoming, born and raised in Wyoming.
Okay,
I worked for a wholesaler from 1996 to 2010. So I've been in the wholesale game. In 2010, I moved to a buying group, or a retail buying group, which most of the independents in the room are members of a buying group. There are a couple that have testified today, as well as a couple in the audience that are current members, customers of mine. So I've been in this business a long time. We help negotiate price with the wholesale side. And all we're doing is aggregating the volume to lower the cost of the medication. And the reason we do that is they're under fire daily due to reimbursement rates. So we're always trying to keep up one step ahead of wherever the PBMs are paying on both brand and generic medicines.
Mr. Chairman, so then with regard to Wyoming and economies of scale, would we be hindered in Wyoming without the PBMs? Would you, as a buying group, still be able to provide a good price and a fair price to us?
Yes.
Okay, thank you.
I love those answers. Those are my favorites when we get yes. Any further questions? No further questions. Thank you very much for coming down. Mr. Martineau couldn't stand to sit back here. Go ahead, sir.
Chairman Baldwin, just another clarifying point to Chairman Wilson's question. So that's a total of 5 retail pharmacies in Wyoming then that would be owned by a company that owns a PBM. And of the ancillary drug box permits that the board issues, 21 of those are run by pharmacies that are owned by PBMs.
Get all that, Chairman Wilson?
Kind of. Now, whether I'll be able to read it late next week is a different question.
You're not a doctor. You can read your writing. Okay, further questions, committee? Thank you very much. Further public comments? Come on down. The mics are warmed up. Go ahead and introduce yourself.
Thank you, Chairman. Thank you. My name is Jancy Walter. I'm an independent pharmacy owner in Torrington, Wyoming. I just wanted to identify myself and made the drive up here to support my colleagues. And I do have to thank all of you for listening to our concerns, and thank you to the people who testified. And if you're in Torrington, welcome to stop by my store.
Any questions, committee? Representative Flitner.
Thank you, Mr. Chairman. You sure you don't want to say something more? You drove all the way up from Torrington?
Only Representative Flitner staying.
The testimony that was presented gives a picture of the challenges we face. And I would just validate the facts that we are paid below our cost, below our invoice cost. We are doing this just to provide jobs to the people in our stores, to provide the services for our people. And it's hard to walk away from serving. So we just keep plugging away. But it is at a desperate point. And I think that you can feel the sentiment of all of us here about how desperate we are.
Thank you.
Any further questions? Thank you very much. Go ahead, ma'am.
Thank you, Senator Chairman Baldwin. I'm Corianne Morgan. I'm a pharmacist here in Riverton. I work for the Northern Arapaho Tribe at the Wind River Cares Pharmacy here in Riverton. I just wanted to speak briefly about specialty pharmacy to Senator Bouchard, if I may. We contract with, just like all the other pharmacies, we have to make contracts with insurance companies, and most of them prevent us from providing specialty medications. One particular patient that we had no home phone number, no address that he could provide to the specialty pharmacy. I had a technician spend 3 hours trying to get the PBM operated insurance company to allow us to fill his medication for rheumatoid arthritis, and they would not, even after 3 hours of trying to answer all the questions and provide all the documentation and diagnosis codes from the doctors, let us get reimbursed for providing that medication to the patient. In the end, we provided it to the patient through other avenues that we get at IHS. It's not IHS, but it's a tribally owned facility. So it was covered for the patient, but it should have been covered through his insurance. But we have a lot of people here in Riverton that are in the same boat that this gentleman would be in, where they don't have access the same way. And if they're forced to use a mail order, which is what a specialty pharmacy is, it's not a specialty pharmacy. It's a mail order pharmacy that forces people who have special disease states to utilize their services because they get better reimbursement. If it wasn't so special, they wouldn't get higher reimbursement and they wouldn't be interested at all in providing those medications to those people. So that is the only reason that they are specialty. And when the gentlewoman from the PBM spoke about how she did not approve of the Texas legislation because it didn't provide enough certification for the pharmacist to provide those medications in a safe manner, I would say that is bogus, because we do have the training and we do make the phone calls when the patient has an ability to be contacted that way. We do use other methods to contact patients when they don't have phones. We have public health. We have people that will drive out and find them. We know who their grandmother is, and we ask their grandmother to get hold of them and send them to the pharmacy. It's time to refill their medication. It's time to get their labs checked. So when they say that we don't have the training and we can't provide the level of the high touch level of service that specialty medications require, I say that's not true. Thank you.
Questions, committee? Go ahead, Senator Bouchard.
Thank you, Mr. Chairman. I can relate. I used to be a mechanic most of my life. I've had cars towed from the Jaguar dealer to a shop that I worked at, and they couldn't fix it. So I think that happens across all trades. We have people that care about our customers, and we have people that are in it for the money only. And I think the money drives some of these policies. My question is, how do these companies create this how do they create the situation where you can only get this drug through that source? I mean, is there a way to go around it, or are we stuck here? And so this is a bigger question. I saw the maybe the West Virginia model as something that we need to look at, but I'm still stuck on the Texas model right now. So what's your feelings on that as well?
I do not know the best way to get around it. I haven't put in the time to try to understand all of the ways, the possible ways around it. There have been times where I have recommended to patients, because I haven't always been at Wind River Cares, but I have recommended to patients to just pay a cash price and then bill their insurance company, because sometimes patients can make a bill and submit it to their insurance company and get reimbursed, but sometimes that's not an option.
Very good follow-up.
Yeah, thank you, Mr. Chairman. So I guess my question is there any, can you buy it anywhere else, or do you have to go through that one place where that PBM is handling? That's my question. So that would be, is it yes or no, or?
Yes, they force you to buy it through them because they have that in their contract.
Okay, and then to follow up on the Texas legislation, I mean, what's your feeling there? Go ahead.
It sounded. There we go. There we go. It sounded like that was a loophole that she wanted to close up. So it sounds like that was good for the independent pharmacies or the regular pharmacies, and where they weren't forced to become certified as a specialty pharmacy in order to receive reimbursement from the insurance company.
Thank you. Further questions, committee? No, okay. Oh, one more follow-up. Go ahead, Senator Bouchard.
Well, I don't know if this is a question or not. What I'm trying to get at is we've seen the model with the Texas legislation, and we also heard about West Virginia. I know there's cost shifting that we have to do sometimes. I mean, you guys are in business to make a profit. I'm worried that if we just did a West Virginia model, that there's still no control at the local level. And that's where I don't see the West Virginia as a standalone. So I just wanted some dialogue in this. And what do we do? I mean, is it the best model to just maybe forge through with a Texas model, and then maybe come back in and look at some of the rebates, how they aren't being passed through? Or, I mean, I know it's a loaded question, but I'm trying to get guidance so everybody here can make a good decision. Go ahead.
Mr. Chairman.
From what I've heard, I would say that would be a working group answer.
Mr. Chairman, this is Scott down in Cheyenne. Sorry, I'm trying to start my video. There's language in contracts with insurance companies and PBMs. It's called freedom of choice and anti-steering. So what that means is all these PBMs, when they force their patients to go to a specialty pharmacy like is being discussed, they lower the patient's copay, or they disincentivize them to use us as an independent, saying your copay is going to be 20% of what that total value based off whatever, if it's an 80-20 reimbursement policy. So like for me, for Blue Cross Blue Shield, if I was on one of those expensive specialty drugs and I haven't met my deductible and it's $5,000, I pay 20% of that copay. Whereas if I went to that Accredo, which is their specialty pharmacy, they would probably say it's either $10 or zero. So they penalize you. And so that's why I say we need to put in the legislation that they can't steer their patients to go mail order specialty, and they have freedom of choice, and they can't get penalized for using their freedom of choice to say, I want to use North Star Pharmacy in Cheyenne, or I want to use Cowboy Drug in Wheatland, or I want to use whatever pharmacy in Riverton, because that's where they're from. So that's the important key is the language and the terminology. Whatever we put in the statute or whatever we put in policy, is that we just say you can't steer your patients and force them to do something they don't want to do.
Well, and we have many patients that come into our pharmacy that have been pushed mail order and ask what we can do to help them get out of mail order. They specifically come to us and say, we would like to get our drugs through you. How do we do that? What is the cost difference? What is the difference. I mean, and when you're looking at models to follow, I mean, Texas has done some really great things, but I think we'd shoot ourselves in the foot. We're Wyoming. We know how we do things in Wyoming, and Wyoming may go a little different. I think we definitely use those frameworks to start forming something, because none of us are legislators here that you're talking to. You guys are. And so we rely on you to help us with those things. We're letting you know what the issue and the problem is. And I think we look at what our options are. And from there, we form the Wyoming model and do what Wyoming needs, because Wyoming is different than every other state.
Very good. Thank you very much. Okay. Thank you very much to everyone who's presented. We really appreciate it. And I would add on here personal thoughts again only. I get that privilege when I'm chairing, is that I appreciate the fact that we have the human spirit and the Wyoming spirit, and that I've heard it several times today. We have patients that can't afford these. It's killing us to give these drugs. It's hurting my business, but we help the patient. We're taking care of the people. And I think we hear that a lot on this committee, not just in pharmacy, in everything we hear. And I appreciate that. And I appreciate all those that have presented that have that spirit. We can't do that forever. At some point, that system breaks and we have to change things. And I think we're at that point. Something's going to have to be adjusted, but I appreciate that spirit. I appreciate everyone that came and presented here and online. Any further comments for these folks, committee? Okay, thank you very much for coming in. And I believe that was everybody online, Katie. We heard everybody. So that brings us to the end of our agenda list. Let's wrap up this subject. And Ms. Co-Chairman, you can reach over and slap me if you don't like anything I say. I would again make the proposal that we form a working group. And I would propose on that working group, we have two members here who have been fairly passionately involved in the discussion here, one on either end of the table. And I would propose that they form the crux of this, but and that would be Representative Flittner and Senator Bouchard. And I would propose that anyone in the audience or anyone who presented today or anyone outside that's listening, including Department of Health. I noticed that Franz was here with us this afternoon listening in, as well as Department of Insurance, that you make an effort to go forth to those people and meet together for however many hours. The downside of this is a voluntary meeting. You're not going to get rich doing this. But I would propose that we form that working group and that you meet as many times as you think it needs between now and September. And I feel like you're on the diving board. And I'm proposing that this working group dive off that diving board, dive into the pool, learn more than what we've learned here today. It's a lot of material in one day. And that you take that, swim in that pool for a while, come up with some answers, dive to the bottom, pick up the coins that somebody threw in, and bring that back to our committee in September. And in September, give us some proposals, give us some ideas of what you come up with, involving all these groups of all these people you've heard with, from farm, from the independent pharmacies, chain pharmacies, from PBMs, everybody, and the payers as well. But that you involve all of them, you bring something back to us. Is that reasonable, Ms. Co-Chair? Would you be willing to do that, Representative Flittner?
Mr. Chairman, yes, I'm happy to do that and work with Senator Bouchard and everybody in the room and online. Yes, and I already have a lovely and talented assistant who's already offered to assist me as well. So, yes.
And I would invite any committee members here that want to participate in that to contact both these two. Is that okay with you, Senator Bouchard?
Yes.
Okay, with that in mind, and I would, LSO, if you could make us a half a day for that in our September meeting, preferably not on the last afternoon. If we can maybe do it on the morning of either day would be fine.
Sounds good.
Yeah, no reason. I volunteered to chair today because it's an easy day. I've had an illness. I'm trying to get over it. I'm a little stressed and I'll never make that choice again. Okay. Any further business, committee, that we need to bring forward or things we need to instruct for LSO as they move forward?
Mr. Chairman?
Senator Hutchins?
Thank you. I know trying to read another state's bills is sometimes kind of complicated. We seem to do a better job of creating bills. Is it possible that LSO can send us Arkansas, the West Virginia, and the Texas model all together in a package so we could have that and read over those?
Mr. Brody?
LSO is willing to collect any statutory provisions you would like for the purposes of the working group. So yeah.
So
please
those
reach out.
3 states, that would be great, so we could read over them.
You got it.
Thank you.
And I would encourage the working group in particular to go out to NCSL, go to CSG, because they will also have more information for you. And they're very willing to give that information out to you. So there's no further instructions for, oh,
Mr. Chairman,
go ahead.
Mr. Chairman, I just received an email today from Speaker Barlow saying that NCSL has got an online prescription drug policy seminar, cost saving strategies for states. They're looking for primary and alternate. I don't know that it's necessarily related to PBMs, but I just wanted to make that notice.
Might I suggest, I love suggesting,
You think it needs to be-
that perhaps you give Speaker Barlow a name of Representative Flitner. It would be something worthwhile for
She
her to
wasn't
do.
listening.
Yeah.
Oh, you weren't listening.
I usually wait
You're
until
gonna be
she's
in
out of the
charge
room.
Children's games.
Okay, is there any further? And I would add to that, NCSL, CSG West, all those organizations have webinars continually. If you get on their sites, and I'm way too busy to get in on all their webinars. I try to get in on the ones I can, but I know that they have webinars about prescriptions, about Medicare, Medicaid, et cetera. It would be worth your time to register for some of those and listen in on some of those things. There's other states, it's other people talking about same problems we have, same issues we have. And I think that's very worthwhile. With that said, if we have no further instructions, I believe we'll adjourn this meeting until September.
Mr. Chairman.
Go ahead, Mr. Brody.
I just wanted to add one more thing. If the committee noticed, LSO did include in your materials a slide deck from NCSL. If you go onto the NCSL website, in their pharmacy benefit manager portal, you can actually watch the webinar that accompanies those slides. So it's a little bit more of a enjoyable experience to sift through that material as opposed to the 60 pages of slides we provided you. So I wanted to throw that out there.
So in your spare time, look in on it. Thank you very much. In that case, last time I'm putting the gavel today. We'll see you in September.